Good evening, Neeraj.
Good evening, Rui ma'am. We
How are
will be
you?
starting in another 1 minute, ma'am.
Okay, fine. शेयर कर
Good evening, everyone. On behalf of IAP Allergy and Applied Immunology chapter, it is my privilege and honor to welcome you all to this very special webinar titled Allergy in Pregnancy Balancing Two Lives. As we know, pregnancy is a unique immunological state. It is a delicate dance between tolerance and protection, and managing allergic disorders during this period demands careful clinical judgment. Allergic rhinitis, asthma, urticaria, eczema, food allergy, and even the question of immunotherapy during pregnancy pose frequent and significant challenges to both allergists and obstetricians alike. Through this evening session, we aim to foster meaningful dialogue and share practical insights on how best to ensure the safety and well being of both the mother and the unborn child. We are also proud to launch our public awareness flyer, Allergy Safety in Pregnancy, in both English and Hindi, to empower families and frontline providers with actionable information. We are fortunate to have an esteemed panel of speakers and moderator who are leaders in their respective fields: immunologists, allergists, dermatologists, pulmonologists, and obstetricians, all coming together to address this important intersection of allergy and maternal care. I would also like to thank our chief guest, Dr. Neelam Mohan ma'am, for gracing this event with her presence and guidance. Let us together make this session interactive, evidence based, and clinically enriching, keeping in mind that every allergic mother is carrying not just her hopes, but the future of two lives. With that, I would like to invite now Dr. Neelam Mohan ma'am, President elect Central IAP, for her inaugural address and release of public awareness flyer. Thank you, ma'am. Ma'am, please.
Thank you so much, Neeraj. As phenomenal work you are doing as the chair of the allergy chapter of Indian Academy of Pediatrics and doing us so proud. And indeed a privilege to be here, you know, to put some opening remarks to such a profound topic, allergies during pregnancy. And I want to just say that pregnancy, the term, when we think about it, it's an immense physiological change. The changes that occur in the women, and especially if there's allergies, whether respiratory or skin or food, they can have a tremendous impact on both the well-being of the mother and the fetus. So the key challenges that we always talk about is the immune modulation during pregnancy and the fluctuations that can happen in allergy symptoms. We are all aware, and as a gastroenterologist, I've always been talking for decades on the gut health and the importance of gut health in especially a pregnant women and the impact it can have on the fetus and the newborn baby and the impact that it can have on the allergies. If it is the right way we look into the gut health of the mother, we can also prevent the allergies in the coming baby. So the experience with this, besides that, the mother can face due to asthma, the rhinitis, etc. Understanding this unpredictability becomes very crucial for healthcare providers because there's a standard no for medicines that most of the physicians give. But then you need to balance what the mother's symptoms are going through. So today's chapter, today's talk, I think is very important because it's going to talk about the so many effects of allergies and asthma, rhinitis, gut health, and also the impact it can have, like the preterm birth, the low birth weight, the complications. and we need to ensure a safety in pregnancy, balancing both the treatment and the safety for the newborn baby. So, some few take home messages, which I'm sure these people will give you: the importance of control, which is critical, to individualized therapy, the preconception, the counseling, and the care, and the multidisciplinary team that you need besides the obstetricians, the energist, etc. Thank you, and I declare this flyer open and declare it for use in public. Bless you, and many more achievements to come for this chapter. Best wishes. Love, Neelam Mohan.
Thank you, ma'am. Thank you very much. Thank you so much. So, with these blessing words of ma'am and the words of wisdom, now let us start with today's program. So, I would first like to invite Dr. Rui Rasool. So, Dr. Rui Rasool is professor and head at Department of Immunology at Sher Kashmir Institute of Medical Sciences, Srinagar. So, ma'am, please start your talk.
So first, Neeraj, good evening to everybody. And first of all, I'm thankful to the IAP team, especially Dr. Neeraj, for giving the opportunity to be on this platform. So I'm first going to share my slides.
So, ma'am will be speaking on immunological changes during pregnancy and delicate balance. Ma'am, please share your slides.
Are my slides visible?
Yes, ma'am, slides are visible. You can start, ma'am.
Okay, thank you. So once again, good evening, everybody. I'm myself, Dr. Ruhi, and the topic which has been given to me is immunological changes during pregnancy, a delicate balance. Pregnancy, as you all know, is a biological wonder where the mother's immune system performs a breathtaking act that is embracing a genetic stranger at the fetus, carrying the half foreign DNA while fiercely guarding against the threats. The immunological balance acts by how mother's immune system has to remain tolerant of paternal MSC antigens, and yet they maintain the normal immune competence for defense against microorganisms. These are the unique set of immunological changes that ensure the successful coexistence of the maternal immune system and the semi-androgenic fetus. And these changes involve modulation of both innate as well as adaptive immune response. As you can see, as far as adaptive immunity is concerned, the responses are diminished, bypassed, or even abrogated, while the regulatory adaptive immunity is enhanced. Innate immunity remains intact. It has two purposes. One is to continue provide the host defense against the infection, and second is to interact with the fetal tissues to promote the successful placentation and pregnancy. Now I will go one by one. First, I will talk about what are the changes which happen in the innate immunity. Number one is the changes in natural killer cells, which in the uterus are known as uterine natural killer cells, and they are different from the peripheral natural cells in having the unusual structural and functional characteristics. They are CD56 positive and CD16 negative, and their main purpose is they suppress the perforin synthesis. Because of that, their suppressive activity is reduced. They are abundant in early pregnancy, and they have a role also in remodeling the maternal spiral arteries, because of which it helps in ensuring the adequate blood flow to the placenta. In addition to the uterine natural killer cells, there are the macrophages. These macrophages are M2 macrophages, and how the normal macrophage gets converted, they are programmed in such a way that from M1 macrophage, they become the M2 macrophage, which have the suppressive mode. That is, they produce the IL-10 and TGF-beta cytokine, and because of this, they have a suppressing nature and are responsible for contributing to the tissue remodeling and tolerance. Third innate immunity is involvement of the dendritic cells. What happens in these decidual dendritic cells? They not only are reduced in number and activity, they become tolerogenic cells, and they control the activation and expansion of these Treg cells. And these Treg cells are very important for maintaining the immune tolerance. As far as changes in adaptive immunity is concerned, it affects both on B cells and T cells. Not only the B cell activity is reduced, which leads to the lower development of the levels of immunoglobulin production. Thus, they prevent the antibody-mediated attacks on fetal antigen. And also, it has an effect on the T cells also, because of which the effector T cell response, especially the Th1 response, is suppressed, while at the same time, it enhances the Th2 immune response. That is, there is skewing towards the Th2 immune response. At the same time, there is increase in the production of T regulatory cells, which are known as also Treg cells. Now, as you can see from this slide, there is a shift in the immune response. Normally, you see there is a balance between Th and Th2 immune response. But what we see in the pregnancy is the Th1 immune response gets downregulated, and because of this, to reduce the risk of attacking the fetal tissues, but at the same time, it increases, there becomes a dominance of Th2 immune profile, which is responsible for promoting the tolerance as well as for preventing the fetal rejection. Now you can see in this slide, how is this intricate balance maintained? As you can see, once there is a normal pregnancy, there is adequate number of these Treg cells. And because of these Treg cells, they cause a strong suppression of not only Th1 and Th17 cells, which are responsible for mediating cytotoxic activity or cytotoxic attack on this fetus. So once there is upregulation of Treg cells, it leads to the strong suppression of Th1 and Th17 cells. Whereas if there is disruption in the pregnancy, if there is the deficiency or depletion of these Treg cells, which we will see once there is any reproductive disturbance, like we can see infertility or spontaneous abortions, recurrent abortions, or preeclampsia, what happens in that system, there is these Treg cells are not increased, they are very less, and because of this, there is a weak suppression of Th1 and Th2 immune response, and which are responsible for causing the cytotoxicity attack on the fetus and leads to the wastage of the fetus. Now, how does this Treg cells produce? Shows a multiple suppressive pathways. They not have the role on this, you can say, this Th1 and Th17 cells. How? By producing IL-10 and TGF-beta, which reduce the proliferation as well as the activation of these cells. It has an effect also on the natural killer cells, so that their suppressive activity is reduced. Natural killer cell does not produce the cytosol. At the same time, dendritic cells become tolerogenic, and also macrophages their actions become suppressor. They don't perform the normal function. Now here you can see the slide. This slide shows the dynamic modulation of immune parameters across the pregnancy trimester. As you can see in this slide, the regulatory immune cells such as Treg cells, which are shown in the red line, and the Breg cells, which are shown in the blue line, they increase, particularly during the first and second trimester, which is contributing to the immune tolerance. At the same time, you can see the innate immune components like neutrophils, intermediate monocytes, and Th2 response, which is shown in the light blue line. It increases steadily across the gestation. In contrast, if you will see about the adaptive immune response, which includes the T cells, natural killer cells, and B cells, which is shown in the green line, they gradually decline. And it is these dynamic shifts which reflect the immunological adaptation that support the fetal tolerance and continues the health and there's continuous progression of the pregnancy. Now, as you can see from this, the immune symphony of the pregnancy, you can see in these trimesters what happens. In the first trimester, it is such a beautiful thing that in first and the last trimester, third trimester, there is a pro-inflammatory cytokine response, while as in the second trimester, there's an anti-inflammatory response. You can see in first trimester, there is immune tolerance. How it is established? As I said, it is because of the uterine natural killer cells. This uterine natural killer cells suppresses the maternal T cell response. And also at the same time, it helps in development of because of the angiogenesis, it helps in development and placentation and placentation and implantation, I can say. And how this is done, this is the reason for these things is because the classic MSC molecule, which I am going to discuss in further slides. Now, as far as second trimester is concerned, there is a stage of uterine quiescence. That means the M2 macrophages and immature dendritic cells create an anti-inflammatory environment. And this, because of these anti-inflammatory response, it is important and it helps it support the fetal growth and prevents immune activation. Whereas as well as third trimester is concerned, you will see again, there is a shift again back to the pro-inflammatory response. There is increase in the Th1 immune response because Th follicular cells increase because it is needed again and pro-inflammatory is responsible because at this time it is needed for uterine contraction and for parturition. As far as you will see, this is here. I will go back. This is as far as this slide, which is showing separate what happens in first, second, and third trimester for innate immunity and for the adaptive immunity. First trimester, you will see because of this, which I will discuss about in next slide, what is their HLA disparity, how is this? These HLA disparities because of the HLA molecules which are secreted by these extravillous trophoblasts, and they cause the suppression, as I said, they cause the suppression of the uterine natural killer cells. This happens in the first trimester. Followed in the second trimester, what happens? There is increase in these suppressive M2 macrophages is there. And it leads to the, as you can see, it leads to the accumulation of immature these immunosuppressive dendritic cells in the decidua. And in the third trimester, these immunosuppressive dendritic cells, they get converted into the stimulatory, I can say, dendritic cell, which are responsible for contributing to the parturition. This was as with regard to the innate immunity. And if we will talk about the adaptive immunity, as you can see in first trimester, there is only 10 to 20% of the CD3 T cells. These are gamma delta positive. And if and in second trimester, there is increase in exhausted and sensitive T cell population and increase in the Th2 immune response with decrease in the Th1 and Th7 response. As well as in the third semester, as you can see in the third semester, this now from Th2 response, it goes back to the Th1 response. There is increase in Th1 and T follicular helper cell expression along with Th17 response, which help us in the parturition as the gestation ends. Now, coming to the what happens in the cytokine profile. As you can see in this, it is such a, from this picture, how beautifully it is showing in the first trimester, how there is increase in the cytokines which are responsible for pro-inflammatory response. Why? Because they are needed for the implantation and placental invasion. And once second trimester comes off, these cytokines get decrease in the level, and instead the anti-inflammatory and regulatory factors come into the place, and these what I can say, these factors, these cytokines come into like IL-2, IL-4, IL-5, and other HLA molecules, and they come into the place, and they show the anti-inflammatory state. Once again, now it goes into the third stage, we reach towards the delivery period. Again, pro-inflammatory phase is started, and it again leads to the production of pro-inflammatory cytokines, which help in uterine contraction and the expulsion of the fetus. This was as far as cytokine profile is concerned, and this slide is as far as hormonal influence is concerned. As you can see, these syncytial trophoblast cells, they secrete the progesterone. This progesterone, they secrete progesterone, estrogen, and HCG. This progesterone in healthy pregnancy is upregulated. As you can see, there is upregulation expression of these progesterone receptors. As you can see, I have shown here in the film that there is PR, that is progesterone receptors. It is in 97 of the patients. It is expressed in 97% of the on the cells of gamma delta TCR positive T cells. Whereas if we will compare with the non-pregnant, there is only 14% increased expression of these progesterone receptors. What happens because of these progesterone receptors? Because of these progesterone receptors, there is increase in PIBF. What is that? That is progesterone inducing blocking factor. And what is that doing, PIBF? It helps in suppresses the natural killer activity. As you can see here, how it helps in suppressing the natural killer activity of this uterine natural killer activity. At the same time, there is, we can say, there it acts on the naive T cells and leads to the polarization towards the Th2 pathway. At the same time, it helps in decreasing in the Th1 pathway. Similarly, if we will go now to the estrogen also enhances Th2 immune response and Treg response, whereas it reduces the Th17 response. And also, importantly, very importantly, it helps in promotes the angiogenesis. How? By secreting the VEGF and PIGF in the spiral arteries. Third is SCG. SCG, syncytial trophoblast secretes the SCG also, which leads to the production of the IL-10. And IL-10, what does IL-10 do? IL-10 leads to the production of the B cells and the T cells. And also, as I said in the previous slide, there is polarization of the macrophages from M0 to the M2 cells, which have a suppressor activity. This is the hormonal influence, as you can see. Now, all these things, whether it is the change in the adaptive immunity, whether it is the cytokine profile, change and the hormonal profile, all these, what is the reason for happening this? And the answer to all these is the role of HLA. The HLA, that is the human lymphocyte incident, they play a very critical role in immune recognition and tolerance during pregnancy. As you can see how beautifully Almighty has created the things that they do not express. These trophocyte cells, trophoblast, they do not, especially the extravillous, they do not express the normal classic MSC class 1, which is known as HLA and HLA-B. Instead, they express only HLA-C molecule and other non-classical molecules, which are HLA-E, HLA-F, and HLA-G. This has been recently seen that it is HLA-G which has a main key role in helping in evading of immune response, as well as it helps in modulating the natural killer cells, as well as it helps in what I can say, it helps in reducing the T cell activity, effector T cell activity. Why? How? These HLA molecules, this HLA-G and HLA-C, they interact with KIR. What is that KIR? KIR is a killer inhibitor receptors which are present on these uterine or decidual natural killer cells. And once they interact with them, they lead to the inhibit the cytotoxic response of these natural killer cells, because of which it helps in promoting the immune tolerance. Now, what is the role of HLA-G? As you can see from this slide, that this HLA-G, which is on the extravillous trophoblasts, it binds to the KR receptors on the natural killer cells, or it binds to the ILT2 receptor present on the macrophage. And in this way, it stimulates the production of, as you can see, IL-6 and IL-8 and VEGF also. So, and because of this, what is doing? It promotes the vascular permeability, angiogenesis, and EVT invasiveness, thereby helping in or participating in remodeling of the spiral arteries. Secondly, if you see in this HLA-G, which are present on the EVTs, it binds to the ILT2 on the natural killer cells, as well as ILT2 and ILT4 on the macrophages, as well as ILT2 on the Treg cells. And because of this, it helps in reduces in the level of cytotoxicity towards the fetal tissue. And third, this HLA-G on the EVT binds to the ILT2 and KAR receptors on the natural killer cells. Because of this, it helps in promotion of the growth promoting factors, as you can see. And because of these growth promoting factors, it helps in facilitating the fetal growth. Now, a very beautiful slide, as you can see, how immunological similarities is seen between the cancer and the pregnancy. It is this, the development of this placenta and fetal-placental communication during pregnancy. It almost mimics a regulated form of cancer. As you can see in this slide, in the cancer, HLA-G causes a suppression. At A place, you can see HLA-G causes a suppression of the natural killer cells activity. And in the placental development, trophoblast expressing this HLA-G induces the killer inhibitory receptors on the natural killer cell. As you can see, it inactivates this natural killer cell and induces the negative signaling in the natural killer cell. Second is at B position, as you can see, both the cancer cells also and decidual stromal cells release the prostaglandins. That has an effect on inhibit this IL-2 production. And this IL-2 production, what is it doing? As you can see, it masks the pro-inflammatory response by the natural killer cell as well as by the Th1 helper cells. Third is these RANTES and other CD20, which are the surface molecules among cancer cells as well as EVTs, that inhibit the pro-inflammatory cellular response. And also, in addition, they produce IDO, that is indole amine 2,3 deoxygenase. What is this IDO is doing? It is toxic to the Th1 cells and thereby ameliorating the Th1 expression, but at the same time, it increases the Treg response. What happens because of this Treg response? It increases the angiogenesis for the fetus and for the cancer survival. That is how there is lot of similarities, because both of them cause the immune invasion, and how there is similarity is drawn between the cancer and the pathogen. Now, as you see, these are the changes. As I have already talked about, I will just give a brush up with this slide, what is it is doing. In healthy pregnancy, you will see innate immunity. At A, what happens, this HLA, because of this HLA disparity on EVTs, it causes the natural killer suppression in the first trimester, as you can see in the slide, and increase the macrophage M2 expression and production of dendritic cells, recruiting chemokines like CCL5. And accumulation of these immunosuppressive dendritic cells is seen in the second trimester. Whereas this is important. Why? For the progression of the pregnancy and differentiation of these, as you can see in the third trimester, these suppressive immunosuppressive dendritic cells, they become again now into the stimulator. You can see the beauty here. From immunosuppression, they are getting converted into the stimulated dendritic cells. Why? This is needed for parturition, that is for maternal fetal rejection. Similarly, as far as adaptive immunity is concerned, which is showing there is, as I said, that there is only 10 to 20% of these CD3 plus T cells exist in first trimester, and then these increased and exhausted and senescent T cell population gets increased. There is increase in Th2 response, there is decrease in Th1 and Th response, and the pro-inflammatory cytokine like interferon gamma and TNF-alpha IL-2 innate limited, they stimulate the macrophages, which in turn helps to regulate the trophocyte invasion by phagocytosis. And this happens in the second trimester, whereas as you can see in the third trimester, there is an increased expression of Th1, increased expression these T follicular helper cells, and decreased expression of Th2 immune response, which is responsible for parturition as the gestation ends. As far as these are immunological changes which happens against the in various complications, I will not go into the detail, but it is, we will see the response which we will see in the first trimester in normal pregnancy, it gets changed. As you can see, there is increase in Th and Th17 response, there is increase in macrophages, there is increase in cytotoxicity, and because of this, and decrease in Tregs, because of this, it leads to the perturbed this placentation. Similarly, when it is gestational diabetes mellitus also, that there is again the immune dysregulation is there, because there is, it causes the cytokine storm IL-1 beta and 18 ligand, as well as increased neutrophilia, which lead into the hyperinflammation and causing the cleavage of CD163 surface marker. Similarly, in the patients who have preterm birth, it leads to the increase in the cytotoxic T cell activity because of the which infiltrates the residua, because there is increase in the Th1 and Th17 response, and decrease in the Treg response. This is in contrast to the normal pregnancy, where we see increase in the Treg response. As well as impact of pregnancy on various diseases concerned, you can see not only it sometimes emulates, sometimes exacerbates, and sometimes unmasks a wide spectrum of disease, which includes autoimmune, infectious, metabolic, and allergic conditions. And these are the disease where it causes, there is exacerbation in the disease, like in SLE and ulcerative colitis, which is the exacerbation of these disease in the pregnancy. I will not go into detail. It's mostly because of the hormones and other antibodies which are produced, autoantibodies. Because of this, there is exacerbation of SLE and ulcerative colitis, whereas there are some diseases which get elevated during pregnancy, like we see rheumatoid arthritis, multiple sclerosis, and Crohn's disease. Why? Because there is, as you can see, pregnancies Th2, because there's a skewing of the Th2 immune shift favoring IL-4 and IL-10, which suppresses the Th activity and reduces the joint pain and symptoms. Similarly, Th1 and Th17 driven inflammation with targeted the central nervous system is seen in multiple sclerosis, and again because of the pregnancy Th shift, these and increased regulatory activity, there is dampening of the inflammatory response. Now, coming to the allergies, we know it is shown that every fifth pregnant woman is affected by allergies. Allergy symptoms existing before pregnancy may either be attenuated or equally often promoted through pregnancy, as there is increased Th2 biased immunomodulation, as I have spoken already, that there is skewing towards the Th2 immune response, because of which there increases suppression of IL-4, IL-5, and other, which leads to the production of the allergy. Similarly, the sex hormones also, like I said, estrogen, progesterone, and prostaglandin also, they also cause a bronchodilatating effect. However, optimal diagnosis and allergy management is vital for ensuring the welfare of the mother, which other speakers is going to discuss about this. And as far as allergy predisposition in pregnancy is concerned, there are certain diseases like allergy in asthma and rhinitis. Symptoms of AR and BAR can improve, worsen, or remain unchanged during pregnancy. About 1/3 of women experience symptom improvement, some experience worsening, and rest have no change. Hormonal changes definitely have an effect, and altered mucosal immunity in the respiratory also influences this condition. Similarly, as far as AD is concerned, it can be exacerbated during pregnancy, again because of the heightened Th2 immune response. Secondly, urticaria anaphylaxis. Pregnancy may increase the risk of urticaria anaphylaxis, and in some women due to the increase of histamine sensitivity and vascular changes. As far as FA is concerned, that is food allergy is concerned, there is no strong evidence which suggests there is no what I can say, there is no evidence which suggests that pregnancy increases the risks of new food allergies. However, those patients who have pre-existing food allergies, they are generally remain unaffected by the pregnancy. As well as fetal allergen sensitization is concerned, although the maternal IgG does not cause a placenta, but allergen exposure during the pregnancy may influence the fetal immune development. And this prenatal exposure to the allergen, it may increase or decrease the allergy risk in the offspring, depending, and that most important time is the time and the context. What is the microenvironmental milieu of the cytokine? And it is because of these cytokine milieu and the environment which will be responsible, it leading to the towards whether there will be, it will lead to the development of allergies or not. Now, what are the various risk factors? And most important among them is, we know, that is the atopicity, or we can say genetic predisposition. As we know, family, as we know that when the parents have allergy, the child, although if the mother and father does not have allergy, the risk is very low. And if one parent is allergic, the risk is 5 to 10%. And if both parents are allergic, the risk is 20 to 40%. But, and about in this 33% is if father is having allergy, and 45% if mother is again having allergy. So again, a risk, again, increased risk. And if both parents are having allergies, and that too, they have the same disease, either BA or AR or any other, the risk exceeds to 60 to 80%. This is the role of I can say atopicity in developing the allergy, in developing the allergies in the offsprings. Secondly, exposure to the tobacco smoke. It is very important. It increases the risk of allergies like asthma, rhinitis, eczema. Babies of mothers who smoke during pregnancy show immune changes linked to the allergies, including Th2 cytokine and Ig levels and eosinophil counts also. Third is alcohol consumption. Alcohol consumption is also very important because it is seen maternal alcohol consumption during pregnancy is linked to the higher Ig levels in the newborns and greater risk of AD in children. And also alcohol should be avoided during pregnancy because of causing the fetal alcohol syndrome, because of risk of causing fetal alcohol syndrome. Similarly, maternal diet. This is very important also. It is shown that maternal intake of vitamin D, zinc, and omega-3 fatty acids offers some protection against childhood allergies. Although the evidence is mixed, high folate levels have shown they have the link to AD. Findings are inconclusive. Avoiding allergenic foods during pregnancy does not reduce the allergy risk and may hinder the tolerance development. So what we have to do is a balanced diet. A mother should take a balanced diet for overall maternal and child health. And third important point, which is another risk factor, is use of anti-acid medication, which most of the pregnant ladies use, especially during the third trimester. Studies have shown that use of these drugs promote sensitization to the foods as well as drugs by increasing the stomach pH and thus raising the risk of allergies in both mother and children. This sensitization has also been linked to higher likelihood of asthma and food allergies in the offspring. And second important, very important factor is insufficient exposure to the environmental bacteria. What happens? Hygiene hypothesis. This suggests that limited exposure to the environmental microbes during the pregnancy and early infancy promotes a Th2 skewed immune response. Another point which is important is cohabitation with the pets. Pet ownership during pregnancy and early childhood influences the allergy risk in children. While cats may reduce and rodents may increase wheezing risk, dogs show both risk as well as the protective effects depending on the context. However, this topic is still controversial, but it is good to avoid the pets during pregnancy. It is still recommended. What I can say, it is still recommended that pets should be avoided during pregnancy because it may affect the, it may be responsible for causing the allergies. So the beautiful thing, what are the key takeaway messages to make it easy to understand? What I can say, to make it concise and easy to understand is pregnancy orchestrates a dynamic immunological transformation to support fetal survival, balanced tolerance, and defense. A trimester-specific immune shift occurs. In first trimester, as you can see, there is tolerance dominates because there is increase in Treg cells and decrease in Th1 and Th17 cells. In second trimester, there's immune consequence fosters fetal growth because there is increase in M2 macrophages and immature dendrocyte cell. And in third trimester, there's again a pro-inflammatory response state which prepares for the labor. How? By increasing again the Th1 immune response and which produces the interleukin 1 beta interferon gamma. Treg cells are very important for maintaining the immune tolerance, and if any dysfunction or depletion is and their depletion is responsible to the lead which lead to the pregnancy complication like PET, like preeclampsia or gestational diabetes mellitus or preterm babies. Similarly, hormones, as I said in the previous slide, is that estrogen, progesterone, HCG, they are important for modulating the immune cell function and driving towards the Th2 immune response and T regulatory dominance. Again, fetal trophoblast is expressing the non-classical and HLA molecule, that is HLA-G, is very important because this HLA-G is responsible for evading the maternal immune attack and facilitates in the placentation. Third point is, another point is pregnancy's immune modulation can improve or worsen en masse. As I said, certain autoimmune diseases get exaggerated while other autoimmune diseases get, while others get decreased, and in some patients allergic conditions gets increased and in some it gets decreased, although the exact cause is still unknown. Th2 bias in pregnancy enhance allergy risk, exacerbates the conditions like asthma, AD, and urticaria in some women, and prenatal immune environment and maternal exposure can influence the fetal allergy susceptibility. These are the some references from which I have made these slides, and with this I say thank you very much.
Thank you, Dr. Ruhi. Actually, this was really, really very great, and you have really presented in a very elaborate manner about all the immunological changes. And there were many things which even I have also learned, and I'm sure that our attendees must have gained so many things that actually pregnancy is considered to be, except the third trimester, it is considered to be high Th2, which is the message. And this Th2 is mainly, you can say, like more allergenic or more allergic type of condition. So definitely this is there. And then you rightly mentioned about different conditions. So let us welcome for our next talk on managing allergic rhinitis and asthma in pregnancy, what's safe. So this will be delivered by Dr. Abhinav Guliani. Dr. Abhinav Guliani is professor and senior pulmonologist at Sir Gangaram Hospital, Delhi. So welcome, Dr. Guliani. Please share your screen.
Hi, sir. I've just sent a request. Thank you very much for inviting me to this forum. And I will now start my screen share. Let me know if...
yes, please go on the slideshow.
All right. Is this visible now, sir?
Yes, please start.
Perfect. So first of all, thank you so much for inviting me for this talk, which is very important and very relevant in today's scenario because everybody tends to have their own opinion during pregnancy. Patients' attendants, even doctors who are pregnant as well. So we've all been there, and what is a fact, what is not a fact. I'll try to elaborate how we can manage allergic rhinitis and asthma in pregnancy, what is safe. So I will start off with what are the anatomic effects. As we all know that in pregnancy, the uterus grows and it sort of pushes the intra-abdominal contents into the thorax. So that causes the diaphragm to get elevated. It widens the subcostal angles and it also widens the AP and transverse diameters of the chest. It can also cause airway edema and friability because of the hormonal changes. The mucosa becomes more secretory, and the amount of secretions and the amount of saliva or the mucosal or the nasal secretions can also increase. So this also leads to problems, not if you're an asthmatic, but maybe if you're an asthmatic or a rhinitis patient, that may affect you. This is a graph which tells you because of these physiological changes, what happens to the various volumes of the lung. So there is a change in both the tidal volume, the minute ventilation. Also, there is a reduction in the residual volume. Why? Because the diaphragm is going up, the rib cage is changing posture. So it leads to almost a 20 to 30% change in the tidal volume and hence resulted in the minute ventilation. Why the change in the minute ventilation is more than the tidal volume is because the respiratory rate also increases. It steadily increases in the latter trimesters. Why? Because you need a higher respiratory rate, you need a higher heart rate to manage the hyperdynamic circulation to provide adequate oxygen and blood to the fetus. Mucosal edema and hyperemia, mainly in the nasal passage and airway, is because of the hormonal changes. There is also increased vascularity and thus more exudation. So the tidal volume can increase up to almost 50%. And during late pregnancy, the diaphragm elevation will reduce the total lung capacity by 4 to 5% and the residual volume by about 20%. As our previous speaker has highlighted, there is a shift from Th1 to Th2 cytokine profile. So why this is important in asthma is because asthma is primarily driven by the type 2 inflammation or the Th2T2 inflammation, where severe asthma may become even more severe and mild asthma can convert to moderate or severe asthma. So this is the what we usually see, the rule of threes or the rule of thirds. One third of pregnant women with asthma will experience worsening. One third will improve, will in fact experience an improvement, and one third will experience no change. So we are hardly bothered about the ones who don't have any change or who have some improvement. They are in fact better. But in the patients who experience worsening, this is the subset we need to focus our treatment for. What are the factors that influence the change? One is basically what was the level of control of asthma before the pregnancy. More severe the asthma, more are the chances that it may worsen. How was the adherence to the medication? Was the patient taking the medication very well, or was she like, oh, maybe I'll take it, maybe I won't? And what are the comorbidities? So these are general asthma control factors as well. So the risks for uncontrolled asthma in pregnancy, the maternal risks, which basically why are we bothered about uncontrolled asthma, is that if the patient's asthma is uncontrolled during pregnancy, it can lead to more exacerbations and hospitalizations. It can lead to higher rate of preeclampsia, also gestational hypertension. Some patients may experience hyperemesis gravidarum because of uncontrolled asthma. Some may have vaginal hemorrhage and some may have an increased risk for cesarean sections. The fetal risk, which is of much more and greater importance, is there is a higher rate of preterm birth and low birth weight in these patients. Some patients also have IUGR because of uncontrolled asthma due to various reasons. There can be neonatal hypoxia. Sometimes there can be increased perinatal mortality because of asthma if the patient goes into a status and causes critical lack of oxygen to the fetus. Hypoglycemia, especially in preterm babies, is very, very common. And this is of concern because if you use the short acting beta agonist, which is the backbone of asthma treatment, more often than not during labor, that can, this is the subset which is more vulnerable to hypoglycemia. So you should be watchful in such patients or in such neonates after birth that for about 24 hours, the glucose control has to be immaculate. So what is our goal over here while treating? What do we sort of look at? The risks of uncontrolled asthma, as we rightly saw in the previous slide, outweigh the risk of most asthma medication. So our treatment goal is to control asthma so that these, whatever we read over here is prevented. And that is very, very possible because most of our medication are absolutely safe. So risk benefit assessment, all these are the general principles of asthma medication use. And for pregnancy, the drugs have been divided into various categories, and most of our medicines, they fall into category B or C. That there is no evidence of harm in animal studies or limited human studies, but benefits definitely outweigh the potential risks. So we should always continue effective therapy. We should avoid any new therapy. What's going on, and if it is controlling asthma, very good. But if you have to sort of initiate a new therapy, you should be a little wary, and you should sort of discuss with the patient and the obstetrician before you initiate anything. The monotherapy versus combination therapy, using the lowest effective dose and the fewest possible medication is what the trick is. Inhaled route is always preferred and it minimizes the systemic absorption. Uh, you should always assess whether giving something outweighs the risk, and the benefit always should be of prime importance. First off, we should never forget the non-pharmacological strategies, which is patient education, management of reflux, allergen avoidance, smoking cessation, and management of the allergens, like if you have pets or if you have more flowering plants, air purifiers, and ensuring a good ventilation, and ensuring that the patient is well vaccinated. These are basics which should not be forgotten before we go on to the next. Inhaled corticosteroids are generally considered safe and effective in pregnancy. The most evidence is with budesonide, and followed by fluticasone propionate, and followed by other inhaled corticosteroids like beclomethasone, mometasone, and cyclesonide. Budesonide, which has the most studies, is often considered the preferred inhaled corticosteroid during pregnancy. Our target is to avoid high doses if possible. If not, of course, if we have to give it, we should. Rather than giving a higher dose of an inhaled corticosteroid, maybe adding an oral corticosteroid would help. Coming to the bronchodilators, both short-acting and long-acting beta agonists are good, and they are considered to be safe and essential during pregnancy. There is no evidence of increased risk of malformations, and they are widely used as per the evidence, and they have a very strong safety record. Coming to the long-acting beta agonists, salmeterol is the most studied one, and this is considered to be very safe. The data also supports it. Formoterol also has been studied and is considered safe in pregnant women. The latest ultra LABAs, vilanterol, olodaterol, they are less studied, but in general, they are considered safe. And if you have to use an ultra long acting beta agonist for compliance benefits, vilanterol, fluticasone is the combination which most people have been using recently. Short acting muscarinic agents associated with SABA, which we all are very familiar with, even non-medicals, dual nebulization, is okay for use in pregnancy, and it is recommended when the patient is not responding to SABA monotherapy. No well-controlled study for the longer acting agents like tiotropium in pregnant women are available. However, they are considered to be safe in studies which have reported its use. So if you have to use something from the longer acting molecules, I would go for tiotropium first. Other controllers like montelukast, which is a leukotriene receptor antagonist, is considered safe. There is limited human data, but no increased risk of malformations has been reported in the data available. Theophylline can be used, preferably in the second or third trimesters, but a moderate dose is considered safe. Why? Because they are relatively poorly tolerated. Already the patient is a little tachycardic. The metabolism is reduced, and because of protein binding, a very frequent dose monitoring is necessary. So they can be used, but if you have to use something else before them, that would be preferable. Oral corticosteroids can definitely be used for severe asthma exacerbations. Their use outweighs the benefit of the use outweighs the risk by a major number. Why? Because you have to maintain a good oxygen level, and if an exacerbation leads to hypoxia, that can lead to a catastrophe. So evidence definitely backs this, and we should use oral corticosteroids at the lowest effective dose possible. Initially, it can be used oral. It can also be used intravenous. And if you're using it in the second or third trimester, you need not even bother about the safety. Coming to biologic therapies are used for severe uncontrolled asthma, and they are quite popular these days, and they are showing good results. omalizumab is the molecule which has been studied the most, and it is one of the oldest molecules in this group. And the studies available did not show any increased risk of major birth defects when the patient was on omalizumab. There is data on mepolizumab as well, and the latest literature in the latest literature, there were some patients in whom these therapies were initiated during pregnancy as well. However, that was not recommended because how would the mother sort of react to a new introduction is something debatable. So if you have to really use something, use oral corticosteroids before biological therapies when the patient is pregnant. So that would be the recommendation. However, if someone is already on a biological therapy, you can continue the biological therapy during pregnancy, and that has not shown to increase any major birth defects. Coming on to allergic rhinitis now. Allergic rhinitis affects almost 20 to 30% of pregnant women. Rhinitis per se, not allergic rhinitis, but which is called rhinorrhea of pregnancy, affects almost 50% of the pregnant women, especially in the first trimester. It is possibly due to the hormonal changes, and it can worsen, improve, or remain unchanged, just like asthma during the course of pregnancy. It can significantly affect the life, sleep, and may exacerbate asthma symptoms as well. Because, on one end, especially in the later trimesters, when your diaphragmatic excursion is compromised, and if your nose is also blocked, you relatively feel very, very breathless. So, controlling rhinitis can also improve asthma control and quality of life. Non pharmacological strategies, just like in control of asthma, should not be forgotten. Allergen avoidance comes to be very, very handy. Nasal saline rinses or sprays like salt spray or maybe gel neti, if someone is doing it very nicely and in a controlled way, are very safe, very effective, and are the first line of symptomatic relief. Air purifiers may help by reducing the airborne allergens, but that is not backed by evidence. Intranasal corticosteroids are the next line of management for allergic rhinitis. All of them, budesonide, fluticasone, propionate, mometasone, have been studied. Budesonide has been studied the most, and this is the first line of pharmacological treatment for persistent allergic rhinitis. They are highly effective with minimal systemic absorption, highlighting the safety, and extensive data supports their safety profile. There are combination nasal sprays available as well, but those are not recommended. Inhaled corticosteroids are solely inhaled corticosteroids are the ones which are recommended. They can be given in a once daily or a twice daily dosing, which can be tapered as per the symptom control. First generation antihistamines are considered safe, like diphenhydramine or chlorpheniramine, but they cause maternal sedation and anticholinergic side effects, and they can reduce milk supply. So, if given a choice, you should probably use the second generation or the H2 antihistamine combinations, which is cetirizine or loratadine. They have a lesser amount of sedation and a good safety profile. The newer ones like fexofenadine and bilastine have also been studied, but not as much as cetirizine or loratadine. They do not increase any chances of malformations in the fetus, and their use after the nasal saline or inhaled corticosteroids have failed is what is recommended. If a patient is already on a combination of, say, montelukast or levocetirizine or cetirizine, they may be continued on that, and that is absolutely safe. Coming on to immunotherapy. So what is immunotherapy? For the audience who do not know what is immunotherapy, it is basically desensitization. It can be given subcutaneously or it can be given sublingually. This is the allergens which are given in a very smaller and a controlled dose when the dose is gradually increased so as to achieve control of the allergies. So what the general recommendation is that it should not be initiated during pregnancy. This is the largest patient database which was available, and it said that if someone was on immunotherapy and they continued during pregnancy, it should be maintained and it should be kept on going. And the patients tolerate it very well without any impact on the fetus. However, new initiation should be avoided because in this study itself, they had incorporated around 110 patients, and among those, 7 patients were actually initiated during the start of their pregnancy. Out of the 7, 3 developed uh, worsening of symptoms. That may be due to possible heightened allergies and atopy. But the general consensus was that if someone is on it already and tolerating it well, you should continue it. But you should preferably do not initiate a new patient. So, what are the nuances during labor, delivery, and postpartum? Now, asthma management during labor should continue as is. And we should ensure rather that the patient is on the usual medication. A short acting beta agonist inhaler or a nebulizer should be readily available and given, as stress, anxiety, hyperventilation can all trigger bronchospasm. Good pain management with an epidural are also beneficial, and all these may lead to an asthma exacerbation where stress levels are very high. Medications which we need to be avoided in labor are the prostaglandin F2 alpha and ergot alkaloids. Prostaglandin E2 and oxytocin are safe and they have not been associated with worsening lung function. Postpartum, you should continue the asthma or allergy medicines as they were going on. Asthma symptoms may revert to pre-pregnancy states within about a few weeks. Now, influenza, I'm mentioning over here very separately. Why? Because all pregnant women are very, very susceptible to the effects of viral infections. We've been seeing an upsurge of viral infections of late. And swine flu carries a very guarded prognosis. The chances of such a person going into ARDS when they are pregnant are very, very high. So treatment, even empirical, outweighs the risk of drug-related adverse effects. Also, it highlights that we should vaccinate all our pregnant women with influenza vaccines, COVID vaccines, and now as RSV vaccines will be available in India, they are also recommended during the latter half of pregnancy, just before the delivery, so that the benefits are passed on to the fetus, preventing RSV infections. Antitussives also deserve a very, very important role. All of us are confused when we see a pregnant patient what antitussive to prefer. So dextromethorphan, which is our usual ZX or Alex, which is in combination, of course, is the safest and most studied one. So dextromethorphan plain is what is recommended. Codeine can also be used, but it is preferably avoided in the first trimester because it can cause sedation and also a lot of emesis. Lactation is usually tolerated very well with most of our medicines, and breastfeeding is very, very safe for patients with allergies, allergic rhinitis, and asthma. The usual and the regular medicines should be continued as ongoing. What we generally say is oral corticosteroids should be timed. If an oral corticosteroid use is needed, timing of the dose after feed to minimize infant exposure is what is said. In allergic rhinitis, as was in pregnancy, second generation oral histamines are usually preferred. So the take home message is we should prioritize disease control. We should not get afraid, oh, this patient is pregnant, oh, this patient is lactating, what do I do? What do I do not? What do I not do? Do what you were usually doing. Consult your pulmonologist. A close collaboration between the obstetrician, pulmonologist, and the patient is very, very essential so that the care can be individualized. And remember, all our medicines, most of our medicines which we are using are safe. Thank you.
Thank you, Dr. Abhinav. Very nice, crisp messages and which were actually required. And you exactly hit everything on the dot. So thank you. Thank you for doing this for us. So please stay back for the panel discussion. And now we'll be moving to our next talk. The next talk will be on atopic dermatitis and urticaria in pregnancy and the challenges in dermatologic care. The reason for keeping this talk is many times we encounter so many pregnant females who are suffering from some skin allergies, particularly urticarias, angioedemas, and the problems are so severe that it is sometimes they have to go up till the extreme steps also. So for discussing this, I would like to request Dr. Shilpa Garg. So Dr. Shilpa is a professor and senior dermatologist at Sir Gangaram Hospital, Delhi, and I'm actually fortunate to have Dr. Shilpa around me because there are so many patients which we work together as a team, not only from the pediatric, even from the adult side also. So welcome, Dr. Shilpa, and thank you very much for joining us today.
Hello, can you hear me?
Yes, we can hear you. Please start.
Can you see the slide also, Dr. Neeraj?
Yes, slides are clear.
Thank you for having me. The topic of my presentation is atopic dermatitis and urticaria in pregnancy. Atopic dermatitis is a chronic, relapsing, inflammatory skin disorder with heterogeneous clinical presentation. Heterogeneous means that it can present with a variety of clinical features of papules, papillovesicles, oozing lesions, dry scaly plaque, thick lesions, prurigo-like lesions, and lichenified lesions. So it has a varied clinical presentation. Atopic dermatitis in pregnancy. Atopic dermatitis is the most common skin disease in pregnancy, accounting for about 1/3 to 50% of all pregnancy dermatosis. In 60 to 80% of the patients, it occurs de novo, that is for the first time, and it is most often seen by the end of second trimester. Sometimes it can occur as a recurrence. So the patient must have been a childhood or infantile atopic dermatitis, and the disease recurs during pregnancy. And there are few patients who are adult onset atopic dermatitis. These patients will experience exacerbation of their disease during pregnancy. So clinically and histologically, the presentation of atopic dermatitis in pregnant and non-pregnant women are almost very similar with hardly any differences. The cause, pregnancy hormones like estrogen and progesterone, they shift the immune response towards Th2 response. They affect the hydration and skin barrier functions. And those are the reasons which are believed that atopic dermatitis tends to worsen during pregnancy. So clinical features, atopic dermatitis starts earlier in gestation. So onset is usually before third trimester in majority of the patients, in around 75% of the patients. And as opposed to this, most of pregnancy specific dermatoses are usually seen to begin in the third trimester of pregnancy. I've already discussed it can present with varied clinical features, skin presentation. And as in adult onset atopic dermatitis, flexures of the body are the most commonly affected sites. The trunk can also be involved. The little slight difference here vis-a-vis adult atopic dermatitis is like in adult onset atopic dermatitis, usually hand and foot eczema and nipple eczema is commonly seen, which can be slightly less frequent in atopic dermatitis seen in pregnant women. What are the important differential diagnoses? Polymorphic eruption of pregnancy, which was called as polymorphic urticarial papules and plaques of pregnancy. The onset of this dermatosis is usually seen in the third trimester. This disease begins as papules or plaques, urticarial looking papules and plaques, which first start within the striae gravidarum, which is your stretch marks. So the lesions appear on the linear radiating stretch marks seen on the lower abdomen and on the upper thighs. And the onset is mostly in the third trimester. Next is pemphigoid gestationalis. It is usually seen in the second and third trimester of pregnancy. And differentiating feature is presence of blisters, bullae and vesicles that are seen. Intrahepatic cholestasis of pregnancy also commonly seen in the third trimester with abnormal LFT and raised bile acid levels. Urticaria is very different. It presents with evanescent wheals, which usually subside in a day or two from one area and move across the body. For scabies, which can be a very close mimicker of atopic dermatitis, you have to ask for history of itching in other family members. Examine the web space, examine the upper thighs, genitals, and that will give you the clue. Contact dermatitis, that is eczema arising due to contact with some external agent. So a good history taking will help. Patient has had contact with any metal, perfume, and you know that it begins with a certain, there is a typical localization to the area on which the allergen was used. Drug reactions can be confused very rarely with atopic dermatitis because normally they involve full body and are not restricted to folds. And history taking is always important to see if there is a new drug which was taken and after that the skin lesions appeared. So diagnosis, it is very difficult to apply criteria of atopic dermatitis in diagnosing these patients. And so a lot of patients would feel that since the disease, uh, patients are not very keen on taking any treatment during pregnancy, they feel that we can leave it unchecked and mostly no harm comes out of it. So what are the adverse effects of atopic dermatitis on pregnancy? You have to counsel the patient also. The skin of these patients may be prone for Staphylococcus aureus colonization, which can lead to premature rupture of membrane and neonatal septicemia. Eczema herpeticum can cause maternal and fetal demise. Uncontrolled atopic dermatitis can result in a systemic pro-inflammatory state, which has been shown to be associated with decreased brain development and prematurity. Patients of atopic dermatitis are usually sleep deprived, anxious, and depressed, and this can also affect the outcome of pregnancy. Treatment of pregnant patient is challenging because it needs to be safe for the fetus. So we are very restricted in our choice of molecule. And also the main cause is patients often resist taking any kind of medication during pregnancy. So this slide summarizes all which you can mostly safely use in treating pregnant women with atopic dermatitis. So the foundation of treatment of atopic dermatitis is moisturizers. Moisturizers improve all aspect of atopic dermatitis. They take care of the dryness of the skin. They decrease the inflammation in the skin. As a result, you can decrease the amount of steroid or calcineurin inhibitors that you will use to treat the patches. They improve pruritus. Moisturizer is the only component which is important in maintenance of treatment. So you have to tell the patient that when all the lesions are all right and every other drug is withdrawn, moisturizer is the only thing that never discontinues. So it has a very important role in preventing both flare and relapse in atopic dermatitis. So how do you choose your moisturizer? So any topical preparation comes in the form of lotion, gels, creams, ointment. And lotion being the lightest, it has the least amount of oil, and ointments being the thickest. So ointments are most moisturizing, but they are so occlusive and so greasy that they are not very patient friendly. So you mostly end up choosing between lotions and cream. How frequently do you moisturize your skin? You moisturize to the point that it doesn't feel dry. If you've chosen a correct moisturizer, usually 2 applications in a day would solve your purpose. So just some examples of good moisturizers with no conflict of interest would be if the patient wants something very light, very non-sticky but hydrating. Especially during summer season, you can go for Sebamed hydrating lotion. And if the skin is very dry and you are towards winter season, you can use Venusia Max lotion or cream. But when you know you are in thick winters or the skin of the patient is very dry and twice daily application of the moisturizers being used is not making a difference, then you go for your body butters. So you have Shea and Cocoa body butters in various brands. Cheap to expensive, Himalaya makes reasonably priced cocoa body butter. And otherwise, if you want to go for very good brands, Body Shop makes very good cocoa body butter. So these are few things that you can write for your patients if they want you to write something in particular. So now coming to, so it is tried that moisturizers would take care of atopic dermatitis in pregnancy as these are the safest. But practically speaking, you need uh, an anti-inflammatory like a steroid or a calcineurin inhibitor to resolve the existing patches of eczema. So topical steroids, they resolve inflammation, decrease pruritus. We broadly classify our topical steroids as low, medium, and high potency. Example being Dizonide and hydrocortisone for low potency, fluticasone, mometasone, and fluocinolone for medium potency, and clobetasol, betamethasone, and halobetasol. So just things to keep in mind is the lowest potency of corticosteroid that would do the trick should be used. So you always start with mild to medium topical corticosteroid in pregnant women. Keep in mind that in the medium category, avoid using fluticasone propionate, which is most commonly comes in the brand of Flutivate cream. It is not recommended for use during pregnancy because of lack of metabolization by the placenta, and so the molecule can reach the fetus in high concentration. So you are left with basically mometasone and hydrocortisone and Dizonide. So if you see that the patches of eczema are very mild, go with hydrocortisone or Dizovin. And if you feel that they are of reasonable severity, you go with mometasone. A good trick to use corticosteroid is always tell the patients of the amount to be applied. So there is a fingertip concept, but just practically speaking, always tell them the minimum amount that is enough to cover the area and absorb the cream in the skin is the right amount. And tell them that application of this cream can cause thinning and whitening of the skin. So apply it only restricted to the area where you have the patch. What you can tell them is always to mix the steroid cream with little bit of coconut oil. They are not totally immiscible in each other, but they can just take the cream and oil on a plate, mix it and apply it. How it helps is that coconut oil or moisturizer, mixing it with steroid, adds a layer of moisturizer, prevents the atrophy and thinning that is seen with Momate or the steroid that you use. And it reinforces to the patient's mind that this cream can cause side effects, and that's the reason they dilute it and apply it. So they will always be careful of the quantity that they apply. Now the space for high to ultra high topical corticosteroids. So once you see that the severity of eczema is very severe, then mometasone may not be able to help. In that case, how you use your ultra potent topical corticosteroid is that you go in for a short period of time. So short-term therapy, just a rescue therapy. You come down in the severity of lesion and then you can shift to a mid-potency steroid. So in non-pregnant patients, we use salicylic acid ointments quite liberally in those cases who have thick lesions because it enhances the desquamation of the thick lesions and the steroid is able to penetrate better. remember to avoid steroid and salicylic acid combinations in pregnant women. Use just plain steroids. So next is topical calcineurin inhibitor. This is also a pregnancy category C drug. It is not really advised that you use them in pregnancy. However, they can be used, especially when you know that there is steroid sensitive areas where you don't want to use steroid because it can cause side effect like lesions on the face, folds, groins. There you can use calcineurin inhibitors like your tacrolimus cream. And it is believed that due to the large size of the molecule, the systemic absorption is less. So it can be used, but with caution. So role of potassium permanganate compresses. Potassium permanganate, it is available in a crystal form. And when you see oozing lesion, when you see it is an acute stage of eczema, and patient will complain that the lesions are oozing. So it helps in drying the lesion. It has antibacterial and antifungal properties also. So you tell these patients to take a bowl of lukewarm water, put just 1 or 2 crystal of potassium permanganate in it, dissolve it completely. The color of water should be very, very light pink color water. It should be almost translucent so that if you put a coin in that water, you should be able to read what's written on the coin. If the water is dark, it will result in burning of the skin. Then you take a hanky or a towel, fold that cloth in 4 folds, and then you dip that cloth in that water, squeeze it, and just put it on that affected area. And you do this for total 15 minutes in a day for next 5 to 7 days till such time you feel the lesion has become dry. So mostly practically speaking, I have never crossed beyond this point in treating pregnant women with atopic dermatitis. And maybe in Indian scenario, we don't see allergies which are very, very severe. And maybe that's why practically we've never used anything beyond that also. So what other options which are available to us is phototherapy, which is broadband or narrowband UVB therapy and UVA1 therapy. Just a word of caution is that UV therapy can lower the folic acid level in the body. So in these patients, you give folic acid supplement. Systemic therapy that can be used in pregnant women is oral antihistamines. This has already been covered, that there is maximum safety data is for cetirizine and loratadine. And oral corticosteroids are used if you see that there is a severe flare and you feel that your super potent topical corticosteroids will also not rescue the situation, then you use oral corticosteroids in a dose of 0.5 milligram per kg body weight. You can just start with 20 milligram in general for 2 to 3 weeks. This is the maximum range. Ideally, we give it for 5 to 7 days, and it usually works within that time. Between the oral corticosteroids, choose prednisolone and not dexamethasone. I have never given cyclosporin A in pregnant women, but in case you need to step it up over oral corticosteroid, then it is cyclosporin A, and after that would be azathioprine. So possible therapy which is available but not recommended at present due to limited evidence is your topical crisaborole and dupilumab. And with both, I've had no experience in any disease so far. What you must never give to pregnant women, what is contraindicated is your PUVA therapy, methotrexate, mycophenolate mofetil. So there are certain things: prevention of atopic disease in unborn child, maternal dietary antigen avoidance is yet not recommended. Certain diet rich in fruits and vegetable, vitamin D and fish has been found to be favorable. Use of probiotic supplement during pregnancy, there is still limitation in the data available. Alcohol use and consumption of alcohol and smoking deteriorates the condition and increases the risk for the child. And maternal stress and depression are also harmful. And a normal delivery is preferred over cesarean section. So now coming to urticaria in pregnancy. And patients with chronic urticaria, they improve during pregnancy in half of the patient and they worsen in 1/3 of the patient. So sometimes very few patients come with acute onset of urticaria, and in our experience, these patients are mostly patients who have gone IVF treatment for their pregnancy and are taking progesterone. So ask for history of drugs, and these progesterone containing drugs can cause urticaria. So treatment ladder is very similar to urticaria in non-pregnancy. That way you start with standard dose of second generation non-sedative H1 antihistamine. If it doesn't work, you updose it to 4-fold. If there is still no response in 2 to 4 weeks, you add omalizumab. And if that is still not working, you move to cyclosporin A. So I've never gone beyond using just antihistamines. I've never used omalizumab in pregnant women and even otherwise. And otherwise, I use cyclosporin if need be, but mostly antihistamines do the job. This has been discussed. Choose loratadine and cetirizine and levocetirizine. Now, these are your pregnancy category B drug. Avoid choosing Allegra and desloratadine. These are pregnancy category C drug. H1 antihistamines are preferably avoided because they are very sedative. If you wish to use, then chlorpheniramine is pregnancy category B. Avoid hydroxyzine. Now, a Montelukast, however, it is not very strongly recommended that you use Montelukast during pregnancy, but if it comes to it, it is a pregnancy category B drug. So if you wish to add and if you feel anti-allergics are not working, you can add Montelukast. Omalizumab is pregnancy category B drug and can be used in those who are refractory to antihistamines. Cyclosporin A is pregnancy category C, and in those who are even omalizumab resistant, should be treated with cyclosporin. Oral corticosteroid use in urticaria is just limited to controlling a severe flare. So dose normally recommended, so you use prednisolone and not dexamethasone. Prednisolone is a pregnancy category B drug. It is advised we normally give 20 milligram every day, and we normally write 1 to 3 days. You tell the patient if you're fine in 1 day, use it for 1 day, or go up to 3 days. You can go up to 5 days also. So this is just used as a rescue therapy, and it comes with its own side effect, which you have to tell the patient that they monitor their blood pressure and diabetes if they are on oral steroids. So the outcome of pregnancy in patient with chronic urticaria were similar to normal population. So that is a good point about urticaria in pregnancy. And with that, I end my presentation. Thank you.
Thank you, Dr. Shilpa. This was really very useful presentation and very useful things which you have spoken about different things like dermatitis and urticaria management in pregnancy. And now we will move to another spectrum. So can you please stop sharing your screen?
Sure.
So now we will move to another spectrum after speaking to respiratory allergies and dermatological allergies. It is the spectrum of food allergy, anaphylaxis, and then immunotherapy. Though I think Dr. Guliani spoke a little bit about immunotherapy, but let us talk a little detail from the allergist view of immunotherapy and food allergy and anaphylaxis. So I would like to invite Dr. Sujata Ramesh. So Dr. Sujata Ramesh is considered to be one of a very big, heavy-footed name in the field of allergy. She is US board certified allergist who has worked as professor in the allergy division at University of Buffalo. She is currently working as senior pediatric allergist at Manipal Hospital, Bangalore, and also she is simultaneously practicing in USA as a leading allergy specialist. So welcome, Dr. Sujata ma'am, and thank you for accepting our invite.
Thank you very much. It is indeed really delightful to be here amongst this eminent faculty. Can you all hear me?
Yes, ma'am.
Okay, perfect. So I will just start sharing my screen here. Share. Okay. Full screen. So when Dr. Neeraj asked me about this topic, I normally don't keep quiet. He said heavy-footed. I also have a big mouth and I don't keep it quiet. But I was a little stunned because there really is not very much data per se in this topic. So what I will do is a lot of it has been covered by the other speakers. And what I will try and do is to give a practical overview. Because at the end of the day, it's the outcomes and it's the patient that we need to be dealing with. So first of all, the most important thing I think is the greatest fear of food allergies, immunotherapy, etc., is anaphylaxis. Now, anaphylaxis, as has been mentioned, particularly in pregnancy, is that we are dealing with 2 lives and the incidence of mortality and anoxic injury, encephalopathy, etc., to the fetus. Although very rare in pregnancy, it's about, I'd say 2 to 3 per 100,000 live births. You don't want that one patient to be your patient. And if you look at the mortality, it's about 5% of those patients who have died due to anaphylaxis during pregnancy. What are the challenges in pregnancy? The BP, as you know, tends to be a little lower, and therefore there is a delay in recognition and diagnosis, particularly of the initial stages of anaphylactic shock. The other issue here is that cutaneous signs are absent in more than 1/3 of these patients. And compounding all of this is the various numerous, differential diagnosis and inherent complications that come along with pregnancy, the different trimesters and different stages, different situations. There is no standard definition of severity across subspecialties, and there is a lack of consensus between subspecialties about how to treat these patients. Controversy about the safety of adrenaline, of the use of adrenaline. People are still very reluctant to use the adrenaline, once there is anaphylaxis, which is really the mainstay of therapy. Now, when you look at the data of several studies, majority of the cases of anaphylaxis have occurred during C-section. About 50 to 75%, have been numbers in various studies, of which the beta-lactam antibiotics are the #1 cause of anaphylaxis. Latex also features quite high, and anesthetic agents. Particularly mortality, the anesthetic agent responsible has been neuromuscular blocking agents. And when you look at anaphylaxis during general anesthesia, it is associated with a higher incidence of mortality because generally if a patient is taken under GA and an emergency, the basic condition itself that the patient needed the emergency adds more complexity and morbidity. So I want to go over anaphylaxis. As you know, it's a severe systemic life-threatening reaction which could result in mortality. And it is a systemic reaction. So you have skin symptoms, flushing, urticaria, angioedema, very rapidly progressing. And the more morbid symptoms would be laryngospasm, so voice change and stridor, wheezing, bronchospasm. You could have GI symptoms, nausea, vomiting, abdominal cramping, diarrhea, and hypotension is a very moribund symptom. So when you talk about anaphylaxis, it's important to recognize the rapid progression, number one. It is also important to decide when to use the adrenaline. So usually if it's more than one organ system or one of the more cardinal symptoms, such as the laryngospasm or, hypotension, then definitely there is no doubt about rushing in and using the adrenaline. So let's look at some of the other issues. So there's a whole host of differential diagnosis, either before delivery or during delivery, which adds other dimensions to this. Conditions such as acute asthma, acute generalized urticaria, acute angioedema, not only the IgE mediated, but the non-IgE mediated hereditary angioedema. This is something to think about because with the C1INH deficiency, hereditary angioedema type 1, 2, and 3, you do have angioedema. And sometimes, particularly when patients are undergoing anesthesia, cesarean sections, intubation, the undiagnosed previous hereditary angioedema could give you laryngeal edema. And the vaginal deliveries or the, when they do C-sections, you certainly could have angioedema if you have a C1INH deficiency or the hereditary angioedema. One thing which is not talked about in the literature, which we need to be cognizant of, is mastocytosis, because patients with mastocytosis could have severe anaphylaxis. So this is something we need to kind of look for in our patients. Differential diagnosis also includes syncope, panic attacks, other kind of immunological, such as thromboid poisoning, other reactions such as MSG, sulfites, etc., and of course, shock, either septic or hypovolemic. Now, during pregnancy, you have pulmonary embolism, pulmonary edema, cardiac complications, hypotension due to spinal block and anesthetic administration, hemorrhage due to abruptio placenta or uterine rupture, CVAs, amniotic fluid embolism, preeclampsia, seizures, etc. Certainly, I'm happy I'm not a gynecologist because they really have to deal with on hand a lot of these other comorbids and other complications during pregnancy and delivery and emergency situations. Now, if you look at the first trimester, no different from other non-pregnant patients, the most common reasons are medications, food, and venom. That is the Hymenoptera venom. Second trimester, it's the antibiotic allergies, particularly beta-lactam, which is used as prophylaxis for C-sections, or when they use the penicillins and the beta-lactam for group B strep infections and prophylaxis. Management of anaphylaxis. It's important to identify patients at risk. You do see that there is an increased incidence in patients who are undergoing C-sections, particularly because of the use of other medications. Latex allergic patients are at high risk, and latex allergy is seen in healthcare workers, dentists, maybe people in the food industry who handle latex gloves, people who've had multiple surgeries, patients with spina bifida and who've had a lot of neurological surgeries. Now, patients who've had a history of previous allergy, that is a previous significant allergic reaction, are at increased risk. Treatment, there is no controversy, there is no doubt about it, that it is adrenaline in a dose of 1:1000 adrenaline, dose of, I would say, 0.5 ml IM, and it is better to treat adequately than undertreat. So 0.5 is a little practical, it's a little easier to read when you're taking a 1 ml syringe. Now, absolutely critical is to ensure adequate circulatory perfusion. Okay, because when you have anaphylaxis, there's tremendous amount of capillary dilatation, there is tremendous amount of third spacing of fluid, hypovolemia, and it is the hypovolemic shock which kills. So it is critical to ensure that the patient circulatory volume is restored. So put in those 2 lines, push fluids immediately, make sure there's adequate fluid resuscitation. Obviously, we need to make sure that there is no hypoxemia, so oxygen to be given. If there is wheezing, you use a bronchodilator. Now, there is a little bit of not proper recommendations about the positioning of the patient. So normally with anaphylaxis, you recommend a recumbent posture, so the reverse Trendelenburg. head down, legs up. So it's certainly a recumbent posture. But in a pregnant woman, particularly, with the gravid uterus, maybe the left lateral decube so that it does not compress the IVC. Now, H1 blockers and steroids, they've really kind of lost their place to a large extent, but certainly you would use all your ammunition. So steroids, yes, particularly if you don't know what the allergen is, because the unknown risk factor. So if the patient, if you don't know what causes the allergy, has caused the event, then those patients are supposed to be at higher risk for severe and biphasic reactions. So therefore, go ahead and use those steroids. Okay, so then make sure you get a tryptase just so that we can document this and we can see if there's any mast cell activation. And once the acute condition is treated, definitely important to refer to an allergy specialist, particularly because the cause of anaphylaxis should be identified, the patient should be tested, and the patient should be given written recommendations with a proper anaphylaxis action plan. It's important also to build consensus among specialists about how to treat, what to treat, and how to manage these patients. And during delivery, the focus is fetal extraction because it's important to decrease the compression on the IVC. So I just want to kind of, when I look back during my career about what really, what case of anaphylaxis have I had during pregnancy that I had to manage. So this is a very interesting 18-year-old Hispanic female who had recurrent episodes of anaphylaxis, and she had 2 or 3 ICU admissions. And she really had pretty severe anaphylaxis. And we were wondering what happened. So ruled out food allergy, ruled out, drug allergies, ruled out every other common cause of allergies. And we found that she had recently been on oral contraceptive pills. And it was not necessarily that when she was on these pills that she had the episodes of anaphylaxis. So it turned out that she would have anaphylaxis sometime when she was off the OCPs also. So she, on history, careful history, we found that she had episodes of anaphylaxis during the luteal phase. So that's when the progesterone, is dominant in your system. So she actually had progesterone sensitivity. So sure enough, she got pregnant. So what do you do at that time? She was reacting to endogenous progesterone. Skin tests are useless at this point because it really doesn't tell you very much. We could not do a progesterone challenge to diagnosis. So the only option, this is a very rare case. So progesterone hypersensitivity. It may start during pregnancy due to intrapartum rising levels of progesterone. Anaphylaxis certainly has been reported. It's very rare, but something to be cognizant about, as has been just mentioned, I think, about progesterone sensitivity. So if the progesterone hypersensitivity occurs before pregnancy, then it may resolve because there is thought to be an auto desensitization, but it could get worse in some situations. The reason why this kind of rang a bell and I remembered it is these days you see a lot of patients who have in vitro, who go in for in vitro for their infertility treatment, and they are exposed to enormous amounts of exogenous progestins. And certainly, yes, progesterone sensitivity has been reported and it's increasing. The bad news is, yes, it's difficult to diagnose and, skin testing and all that is difficult. So you may need to do a progesterone challenge. The good news is if it is an allergic sensitivity to exogenous progestins, they do tolerate other formulations of progestins or progesterone. And if they do have progesterone hypersensitivity during pregnancy, then we can consider desensitization to progesterone. And in this situation, omalizumab has been found to be useful. This is just kind of a rare situation, but I just thought considering pregnancy and some of these cases that we are seeing, I just, it was interesting for me to mention it to you. Switching gears to food allergy. Now, food allergy, it really is no different. I think Dr. Ruhi had mentioned from allergies, food allergy during pregnancy, whereas food allergies in non-pregnant women. One thing we have to consider is, one thing is food allergy per se. It usually occurs in patients who are known to have these food allergies and most often due to inadvertent exposure, say either a cross-contamination or they go out and eat somewhere and their allergen is hidden. And usually you don't quite develop new sensitivities during pregnancy, but there are a lot of food fads and dietary issues and medications and other things that are given to a pregnant woman, and a lot of concepts about what causes heat and cool and so on and so forth, which we need to kind of consider, because patients have their own ideas about what is allergic and what is not, and we need to educate them. The other thing which has been brought up and just about discussed is, can we prevent the development of allergies in the infant by modifying the diet? So I'm not going to go into it. We can save that for discussion. I think it's important to look at this age-old slide where most of the reactions are non-immunological mediations. And most of them are intolerances, non-allergic hypersensitivity, such as lactase deficiency. And for example, pharmacological effects, such as, with caffeine, tyramine, headaches, cheese, chocolate, sherry, red wine, all of these cause other intolerances and symptoms. Bacterial food poisoning, and then you have the masquerader scomboid fish poisoning. You also have a lot of patients with food aversions and tremendous amount of food fads, which they perceive as allergies, and they go get all of these, blood tests, all these panels, which are quite meaningless, and they think they're allergic to each one of them. Some exotic things come up there, and that's something we need to be aware of, and we need to know how to approach, how to distinguish. We have to focus, very, very important, what is a true allergy, particularly an IgE mediated immediate onset sensitivity, which could then some of these patients could be so exquisitely sensitive that they could have anaphylaxis. There are some non-IgE mediated delayed reactions as well. So if you look at the spectrum, we know of rashes, urticaria, angioedema, respiratory asthma, rhinitis. You also have a whole lot of GI sensitivities, such as GI anaphylaxis, which is after an hour or so after consuming the food, patients could become hypotensive. And the oral allergy syndromes, which may be mild with just some itching and pruritus, but there are some patients who could actually have anaphylaxis when they're sensitive to, some of these fresh fruits, etc. What we have to be cognizant of and to recognize is a systemic anaphylaxis. There are some, unusual associations, such as food-associated exercise-induced anaphylaxis, which we need to, see the relationship between intake of food and immediate exercise in order to diagnose and distinguish these situations. So when you look at the spectrum of food allergies in India, in the adults, I think cashew nut allergy is quite common, and we see a lot of chickpeas allergy, that is the kabuli chana allergy. We see some lentil allergies. You also have certainly the shrimp and prawn and fish allergies. There are also some non-specific histamine liberators, such as brinjal and yams and so on. Now, there have been an increased incidence of wheat allergy in adults, especially with wheat-induced, exercise-induced anaphylaxis. And this is due to antibody to omega-5 gliadin antibody. So I have been seeing quite a few cases lately. So I thought I'd bring that up. Now, it's important to know that most of the patients who have died due to anaphylaxis, food allergies, they've had a previous non-fatal reaction to food. So they knew they were allergic. Most of them were atopic, and certainly asthma is a risk factor for severe food allergy anaphylaxis. They only took oral antihistamine. They had epinephrine, but they did not use them. And again, there's a tremendous underuse of adrenaline. People treated with oral antihistamines, with steroids, IV, etc. But the epinephrine or the adrenaline is just very underused in most centers. And we really, really need to emphasize the education on the need to use the adrenaline as a first line for anaphylaxis. So this is a very interesting patient. About 30-year-old, developed anaphylaxis after eating ice cream. She was pregnant. She had a craving. She ate a lot of things. And she had bona fide anaphylaxis, and she also had a similar anaphylaxis some time back. No history of allergies to milk, eggs, or nut, which are the common ingredients that you suspect with anaphylaxis, with ice cream. So what was causing her, anaphylaxis? So we had to ask her to go back to where she had this, find out what they used. So what they used was, she just had caramel topping, which caramel is nothing but, sweetened or burnt or caramelized sugar. So then what they had used was this butterscotch topping, which has some caramel. And guess what? The flavoring was fenugreek, which is methi seeds. So she had an anaphylaxis to unusual to methi seeds. And I've seen a couple of patients, Indian patients actually in the US, who developed sensitivity to methi because it's used as a secretagogue. It's supposed to increase the milk production. And people have developed a sensitivity. They use a lot of it. So I just thought it's interesting to mention. But the bottom line of presenting this case is to show that we have to get a good history, find out what the hidden ingredient is, identify the allergen, and educate the patient to avoid, what they're very sensitive to. Another unusual case where you do have anaphylaxis. This is a doctor who had anaphylaxis on 3 episodes, and he had been out in the park jogging. And every time he had the same thing, he would have apple juice or, the Tropicana juice, and then come to the hospital and eat breakfast in the hospital cafeteria. So what was unusual, all these 3 times, and he needed the epinephrine also on these occasions, pretty severe anaphylaxis. So we went back to the history. It was usually when he jogged in the morning in the springtime. And what was unusual at these 3 times was, instead of drinking his usual Tropicana, he had fresh apple juice. So he had food-induced, exercise-induced anaphylaxis. He was birch sensitive. That was a time there was birch pollens, in springtime. So you certainly can have food-induced, exercise-induced anaphylaxis due to cross-reactivities between, several of these banana, latex, kiwi, ragweed, melon, birch, apple, etc. So important in unusual cases to get a good history. So switching gears to allergen immunotherapy in pregnancy. So common question that used to be asked by patients, hey doc, can I continue to get allergy shots during pregnancy? And the answer, yes, it is safe to take, but it should be monitored under a specialist, because you could have allergic reactions when you are increasing the doses. And these reactions, though rare, can be harmful to the fetus. So allergy shots are not started during pregnancy, but it can be continued during pregnancy. Now, here again, if the patient has built up to a level of certain concentration and they're tolerating and they're benefiting from it, yes, it is wise to continue the immunotherapy. The doses should not be increased until after delivery. And it's really important that managing the symptoms during pregnancy, as has been mentioned, control of the basic allergic rhinitis or asthma is important. Now, this is old data. So what is the latest regarding allergen immunotherapy and pregnancy? So there have been several studies, and they have been mentioned by our previous speakers. So I'll be very brief. So when you talk about allergen immunotherapy, of subcutaneous immunotherapy, for the most part for the aeroallergens, sublingual immunotherapy for aeroallergens, and, the oral immunotherapy for food allergens, to desensitize probably the younger children to food allergies. So subcutaneous immunotherapy, increasing doses, you have to build up. Sublingual drops and tablets. Again, the sublingual drops, you had to build up and come in weekly to build up your, to reach the therapeutic concentration. You have now these split tablets where you start with a dose, there is no build-up, and you continue the doses. Now, there have been several studies which looked at the data of use of either sublingual, a couple of studies of subcutaneous, a couple of studies in sublingual, and it has been found, particularly in one of the studies, which is a Swedish national database population study by Mitzlo, where they looked at, they compared patients who are pregnant, who are receiving allergen immunotherapy from 3 months before gestation to week 22, compared to a population, about 750 of these pregnant patients, compared to about almost 10,000 of controls. And they found that there is no significant difference between either prematurity, congenital malformations, perinatal deaths, hypertension, proteinuria in the mother, or no difference in maternal or fetal complications. So basically, they did a study to look at congenital malformation. They looked at other pregnancy outcomes. And then there was really no difference in this and a couple of other studies. And then they look also at those who experienced generalized allergic reactions during immunotherapy, and they found that there were no fetal complications. So generally, it is found that it is relatively safe to use either subcutaneous or sublingual immunotherapy. And it is safe to continue allergen immunotherapy during pregnancy. And these studies looked at inhalant allergens as well as venom immunotherapy. And they also looked at a couple of things where in these studies, there was no significant prevention of development of allergy in the infants, number one. Number two, they also looked at, I think I'll go to the next slide on that. So yes, they looked at, is it safe to initiate therapy? So one of the other outcomes that were looked at by Mitchell was when immunotherapy was started during pregnancy, were there complications? And they found that when immunotherapy was started during pregnancy, there was no congenital malformations in the infants, number one. Number two, they found that it was relatively safe. And therefore, there's more data nowadays to suggest that it is okay to initiate allergen immunotherapy during pregnancy. Now, I just want to give you a little bit of context in this. A lot of the older studies were based on the subcutaneous immunotherapy. A lot of them, where there were all these adverse effects, were based on the older non-standard extracts that were used. So when these non-standard extracts were used, there have been quite a few reactions, because the tendency in those days when we first started immunotherapy was to really push to as high a therapeutic dose. Obviously, when you push it so high, you do then have, you pay for it, you do have an increased incidence of systemic reactions. So once increased incidence of systemic reactions were observed, then, the top dose was kind of toned down to a safer therapeutic dose. So it's kind of difficult to compare the older studies with the newer studies. Definitely, I would say that if at all you're using allergen immunotherapy, make sure you are using standardized extracts. Because when you use non-standard extracts, when, the storage and the different kind of extracts, you have dose alterations. And when you have increased doses, that happen because your extracts are not stored and it's not standardized and there's batch-to-batch variability, that is where there is a risk of developing reactions. So we have to be careful to make sure that standardized extracts are the way to go. Okay. So switching gears a little bit over here, can allergy immunotherapy prevent the development of atopy? So do maternal antibodies to allergens, that is the IgG antibodies, IgE obviously doesn't cross through the placenta. Maternal antibodies to allergen, do they protect the offspring? So observational birth cohort studies show that allergic sensitization occur very early. And there's an interesting study where they investigated if passive transfer of allergen-specific antibodies, the IgG, could convey protection from sensitization to the offspring. So actually, when they studied patients up to about the first 5 years of life in this cohort, it was interesting to know that the IgG that was passively transferred to the mother, to the infants, protected the offsprings from developing allergic sensitization to that specific allergen. So there is a suggestion that the transfer of maternal IgG antibodies from mother to child in utero can confer protection from allergies in these children. So it just gives you a kind of a thought, is this a novel strategy for prophylaxis of allergies based on the induction of this allergy-specific IgG, which is kind of like a vaccination or on passive administration of allergen-specific IgG to pregnant women. So this is an interesting concept. And I know it's just not only the IgG, but there is a whole lot of other factors, such as I know Dr. Neelam was mentioning, the gut flora, the nature of delivery, the other things, the foods, the other things that the mother is exposed to. So it is a very multifactorial issue that we have to look at and study and think about. And you also know that there's an increased risk, as was mentioned, to food allergies in children born after C-section delivery, LGA patients, etc. So I think we're almost out of time. Probably I would just like to conclude over here. We can leave the rest for discussion. That it's really important in all of these situations to recognize anaphylaxis, to initiate adrenaline 1:1,000, the dose 0.5 ml IM, antihistamine to be used, and IV fluid resuscitation, blood pressure support, circulatory support is absolutely critical, and to have adequate oxygenation. So to summarize, we have to assess risk during pregnancy, risk reduction, confirm anaphylaxis, and obviously, if it's a known allergen, we have to avoid those. Emergency preparedness is absolutely essential, where we make sure they understand the need for using adrenaline or epinephrine, give an anaphylaxis action plan, educate the patient, have a medic alert, and epinephrine, EpiPen, know how to use it correctly. And I'm just putting up EpiPen here because some people are importing it in India and it's available. Certain vendors have it. Know how to use it correctly is important. And here is a child, though, to show how magically, within seconds, once you initiate the EpiPen, the epinephrine or the adrenaline, there's instant reversal of the anaphylaxis within seconds. It's really, really critical that you should know how to use it and you initiate the use, whenever it is indicated. And now, for those who don't like needles, there is a new kid on the block, which is nasal epinephrine. So that is, a spray, one-time dose. So it's kind of easy to use. We don't have too much data during pregnancy, but I'm sure once the data comes and the post-marketing comes, we should have more data available on other options for the use of adrenaline or epinephrine. So I think I will end over here. Thank you very much.
Thank you very much, ma'am. I think it was a very nice presentation, and you really have put down some important facts and important messages which were very much necessary today. Now we will come to the panel discussion, and we will be joined by two more faculties with us. And one is Dr. Veena Singh Gupta. Dr. Veena Singh Gupta will be moderating the panel discussion, and she is a trained pediatric allergist and currently working as senior consultant and head at Department of Pediatrics at Jindal Hospital, Hisar. And we will also be joined by an eminent uh, obstetrician and gynecologist of the country. She is professor and senior consultant, Dr. Sakshi Nair at Sargangaram Hospital, Delhi. So I would like to hand over to Dr. Veena. Dr. Veena, please take the charge.
Thank you, Nihir sir. Good evening, everyone. First of all, I would definitely like to start by thanking Dr. Neeraj for giving me this opportunity to moderate this important session. Well, definitely it is a complicated and a very interesting topic, requires a multifaceted approach, requires a multidisciplinary approach. So we are very lucky to have a panel here today, which comes from different disciplines. We have gynecologists, we have pulmonologists, we have an allergologist, and we have a dermatologist. So with their collective expertise, we'll go ahead and look at different case scenarios. I'll be presenting the case scenarios in brief, and thereafter handing it over to my panelists to offer their perspective on it, offer best case management scenarios, and to advise strategies for going forward with these cases. So I'll start sharing my screen. Just a moment. Sorry, just give me a moment here. So I'll just start by sharing the case. So we have a 28-year-old female patient here who had difficult to control asthma and allergic rhinitis. Now she has a history of persistent cough, wheeze, breathlessness on exertion for almost a month. For the past 7 days, she has also had repeated nocturnal exacerbations and has severe exacerbation for a few hours. So, she has been on regular ICS LABA, formoterol and budesonide for the past 1 year. And she's been on LTRA, she's been on montelukast, azilastine, and fluticasone nasal spray BD for the past 1 year. Also, she has a history of amenorrhea for 2 months, for which a UPT was done and which was positive. The tests which were done, the SPT was positive to house dust mite, Deutero, Parthenium, Prosopis, and cockroach. Specific IgE to milk, shellfish, Deutero, and Emblomiama, positive. And the patient was also on allergen immunotherapy to house dust mite, deuteronesis, and Parthenium for 2 months. So at presentation and emergency, the patient was anxious, tired, could barely talk. She had audible wheeze both in inspiration and expiration. Respiratory rate was about 25 per minute. There were severe retractions. Saturation was 89% on room air. Bilateral air entry was decreased. So I'll start with Dr. Abhinav. Dr. Abhinav, can you please advise how will you start by managing this case in terms of acute management? Are there any additional history or tests that you would require? And what would you advise regarding continuing or discontinuing medications considering the UPT is positive?
So clearly, as you explained, that this patient has allergic tendencies quite severe enough to be on a combination inhaler for over a year, and also allergic rhinitis since she's on inhaled nasal sprays. I don't know why she was not controlled earlier with probably an additional controller. So, having said that, she is on immunotherapy as well. So, what would be the status? I would definitely want to know if there is any history of previous exacerbations, one, since that would help decide that is this the first exacerbation or is it something which she's sort of used to? One.
Okay.
Second component that in management, right now she needs emergency management. She's hypoxic, she's tachypnic, she's definitely in a severe exacerbation. So she needs to be first off explained that she needs to be in hospital and preferably in a critical care setup, something like a high dependency unit or an ICU. Second, we would start off with bronchodilation, short-acting beta agonist in a combination with a short-acting muscarinic agent. Both of them in the nebulized form, preferably because she's on inhalers and not getting better. Third, she should be on oxygen because she's hypoxic. And fourth, she should be definitely started off on hydrocortisone or methylprednisone as the physician who sees her would. She should be initiated on IV steroids. Presently, our focus should be on saving her rather than the fact that her UPT is positive and she may be pregnant, and that should not sort of cloud our management in such a patient. She should be managed like any severe exacerbation of asthma. So switching the bronchodilators from inhalers to nebulizers, initiating oxygen, initiating steroids, IV steroids, that would be the treatment part of it. And from the management perspective, where you require some sort of investigation, of course, she would warrant that if this is an infective exacerbation or not, basic blood work. And if we are not contemplating a chest X-ray or immediately, that would also be okay, and see how she progresses. Maybe do a bedside ultrasound and a point of care ultrasound, and that should give us some headway. One more component in the management would be to what were the pressures? Was she hypotensive? Was she not? Was she febrile in the recent past? I would also want to know that. If this is an infective exacerbation, I would want to initiate her on antibiotic therapy a little early rather than late after sending cultures.
Thank you so much. Now, to give a little bit of background on the patient, she has been a known case of asthma and allergic rhinitis for the past 6 years. Since 6 years of age, has a strong family history. Both parents are asthmatic. Had a history of milk allergy in childhood, which she apparently outgrew. There was a rash, suggestive atopic dermatitis, but which was not physician documented. She has had a history of recurrent throat infections and has had a tonsilloadenoidectomy done at 8 years of age. Also, she had needed 2 admissions in the past year, in the months of April and November, and needed systemic steroids to manage her case. At this point in time, I'd like to involve Dr. Sakshi also to suggest that suggest what would be the concerns from the point of feto-maternal health. What are the risks to mother and the baby?
First of all, I would like to thank you, Dr. Neeraj, for involving me in this panel. The thing, as Dr. Abhinav has rightly cleared, that she's a known case of asthma. Along with that, she's come in a severe exacerbation. So, mother is the most important for us. Right now, she is 8 to 9 weeks of pregnancy. Honestly, in the first trimester, fetal hypoxia does not hamper the fetus as much. So, the first and the foremost, we have to manage, as per Dr. Abhinav said, the severe case of asthma. Regarding the fetus, the only thing we have to document is we have to do an ultrasound for the fetus to document whether there's a cardiac activity or not. The thing is that she's just 8 to 9 weeks of pregnancy. We also have to do an ectopic pregnancy as well, because it's an incidental finding of her being UPT positive. And also, at the same time, we have to counsel the parents, the mother, if she's in the state, and counsel the husband, the partner, that there can be a risk of miscarriage also. But the mother is the most important right now.
Very well said. So agreed, the mother takes priority there and is utmost importance to prevent hypoxia to both the mother and the ongoing. So let's at this point of time assume that it is a UPT positive patient and she is pregnant and it's not an ectopic. After 1 hour of management, the patient is still lethargic. She's tiring, she's sweating, she's unable to speak, and there is still an audible wheeze. Air entry is still poor. Saturation is about 90% on 100% oxygen. So come to Dr. Sujata. How will you manage the patient at this stage? Can please mention the safe drugs? Also keeping in mind the possibility the patient is going to respiratory failure, may need intubation and ventilation, maybe HFNC to assist management.
Okay, I'm not an intensivist. I'm only an allergist. So at that point, I think I would also get Dr. Abhinav's help in this. So obviously, you know, your steroids, you've used your bronchodilator. That's not helping. So I'm wondering at this point, what else can we add to the armamentarium?
So basically, what I would say is we add an injectable methylxanthine, something like aminophylline or theophylline,
We use, yes.
and nebulized adrenaline, maybe even subcutaneous. So since she's not budging in about 1 hour of resuscitation and she's on 100% oxygen, it would not be unwise to electively ventilate her.
Okay, so the other thing also, the other thing also, I mean, sometimes we add ipratropium because sometimes, you know, even though the oxygen sats is so low, it could kind of go up. Yeah, you mentioned that.
So I mentioned the short-acting muscarinic agents. That is the first line, ma'am. So what you usually would do is a combination of a short-acting beta agonist and a short-acting muscarinic agent, which is by the proprietary name of Duolin, which comes by Cipla. You give that with a gap of every 15 minutes consecutively till the spasm sort of breaks. But what Dr. Veena is telling is that despite that, if it is not breaking, I think you have to sort of step up the therapy for managing the severe asthma. You rightly pointed out that ipratropium and levosalbutamol we would probably want to give nebulized, and with that, if she's not helped, then we'll have to step up to maybe introducing something like adrenaline, manage it something like an acute atopic attack itself.
And at what stage would you intubate? I mean, would you do the blood gases at that point, or would you clinically,
Of course,
electively
of course.
intubate?
I think she fits the bill to get intubated. Any asthmatic who is hypoxic is very bad for me, because if you are hypoxic, that means your bronchospasm is very, very severe, and you would probably want mechanical intubation. You want some muscle relaxants in there. You want probably ketamine or propofol as secondary bronchodilators at this stage. Blood gases, I'm assuming that blood gas would be the first thing you would have done when she walks into the casualty with a saturation of 89. But despite that, having said that, uh, I would not have kept the patient on just a high flow or 100% of oxygen for an hour. I would have put the patient on something like a positive pressure device with a non-invasive ventilator or an NIV already. And as Dr. Veena pointed out, that HFNC can also help, but HFNC would have helped in the initial phase. And we prefer HFNC when there is pure hypoxia. These patients with a bronchospasm would, as Dr. Sujata rightly pointed, would be retaining some carbon dioxide. And that is why the preference would not be a high flow oxygen cannula right away. It would be a non-invasive ventilator.
So, Dr.
So-
Abhinav, just now, sorry. Yeah, so we have actually worked together, and normally what I've seen is elective ventilation earlier helps a lot,
Correct.
right? Because it helps to safeguard the mother as well as the
Correct.
fetus.
Correct.
So thank the gynecologist and the intensive for rescuing me. Okay, but what I would like to, look
Nee.
into is she's had 2 episodes, where she needed oral steroids. And if you look at the medications, was she compliant? Are there other comorbids? Did she have sinusitis? There's a tremendous fear of taking steroids, as I think Dr. Shakshi had mentioned. And this combination of formoterol and budesonide. Now, budesonide, yes, it's been used a lot, but it really is not the most potent of the inhaled steroids. And I find that the combination of either, salmeterol or formoterol along with maybe fluticasone works as a more potent combination, number one, in terms of prevention. Number two, the device also makes a very big difference. So, usually the adults don't like to huff and puff with the spacer. So you have some of the newer devices, such as the Synchro Breathe and all that, which, you have to see what device is useful. The third thing is, I wonder what stage of immunotherapy drops she was getting, I'm assuming. Okay, so if they were also increasing the immunotherapy during, she was pregnant now, obviously she's only within 8 weeks, so it may not have made much of a difference, but I would go into what exactly she's getting in terms of immunotherapy. Were they really
She was
giving the
getting
doses?
house dust
Yeah,
mite and
she
Parthenium.
is. Yes, she is getting house dust mite and Parthenium, and you said something else you'd mentioned.
I
But the thing
mentioned
is,
Prosopis. Yeah.
yeah, prosopis, house dust mite, and Parthenium. The thing is, what concentrations were they giving? Were they formulating it correctly? Something we definitely need to look into, because sometimes if the allergen is not chosen correctly, you're actually sensitizing and oversensitizing a patient to something probably, you shouldn't be giving. So we need to relook at the immunotherapy also. I think that's another important thing. And definitely look at comorbids in this patient, other comorbids that we need to treat. GE reflux, she's waking up in the middle of the night with something. She has this exacerbation for 2 hours in the night. So we need to get a proper history, exercise symptoms, other symptoms of asthma control, rule out GE reflux, rule out other comorbids. It's important to get a
Absolutely.
complete history.
Pregnancy predisposes to more GE reflux. Probably that's
I
something
think
to
so.
look
Yeah.
at.
Yeah.
So does worsening of asthma. Nocturnal
That's
symptoms
it.
are very common.
Yeah.
So that could be that could be there. And as you mentioned, ma'am, regarding salmeterol and fluticasone, just as a part of the discussion for that, so budesonide and formoterol combination has been the most widely studied combination. I would not put salmeterol fluticasone to be superior to that, both with my own clinical perspective and the data. Definitely, it is more potent, but that is just reducing your effective dose. It is not actually reducing how much you are taking or whether it will control your asthma or not. One. Second, salmeterol is rather less well tolerated by most patients. Many patients complain of headaches with salmeterol. These are post hoc analysis. And device, as you correctly mentioned, that of course we should definitely look into that. That is one of the most common mistakes that patients are making and not getting control, that they're not using their device properly. It should be, and wherever possible, should be told to be used with a spacer. Or if it is not working, switch the device. If that is also not working, I would have put this patient on a nebulizer long ago. That would ensure that the medicine is going in correctly. And if still it is not controlled, then we have to move beyond the device and the drug. Luckily, budesonide formoterol combination is also available as a nebulizer, which is the advantage of this combination, that you can easily switch. And newer molecules which are coming in combination with the inhaled corticosteroids and bronchodilators, they have added longer acting, ultra long acting beta agonists and ultra long acting muscarinic agents. And those devices with either Astra's Breztri or GSK's Trelegy, which come as a dry powder inhaler, they sort of ensure that even with a bad technique, most of the drug goes in. So those can be options where your asthma is not controlled. Now the studies have come up for those two triple combinations, which were initially only for COPD patients. Just to add on to what basically our discussion was. There is also a very big role of biologicals in such patients. If we've ruled out the usuals that this is asthma, this is severe asthma, the device and everything is okay, and along with the immunotherapy, we should be evaluating this patient for biological therapy as well.
What is a biological therapy? I'm not aware of.
So the antibodies, as ma'am was talking about omalizumab in her talk.
Okay.
So these are therapies targeted towards or against the type 2 inflammation. So this is basically added as controller therapy. So in asthma, you have relievers and controllers. So relievers are the bronchodilators and controllers are inhaled corticosteroids, leukotriene agents like montelukast. And a third controller can be something like a biological, which can reduce the overall immune cascade and reduce the type 2 inflammation and hence the bronchial inflammation.
The other thing also, just to add another point over here, much appreciated the way you've concisely summarized the whole thing. The other thing also is in this patient, we have to evaluate. There are some patients, now we look at T1, T1 asthma and T2 asthma. So some of these patients who are atypical and do not respond, they are the later onset at a slightly older age, post-pubertal onset asthma, female patients, they have obesity. They tend to be obese. They tend not to respond to the inhaled steroids, the conventional therapy. So this is a whole different kind of a phenotype which we need to evaluate. So this patient, once she's better, the acute crisis, a serum IgE, total serum IgE, eosinophil count, other markers need to be looked at to see again if she is somebody who will benefit, who's more neutrophilic, who's more, not typically your IgE mediated eosinophilic phenotype, where a biological may be indicated or some alternative therapy, something to be reassessed in such patients.
Even for neutrophilic predominant patients now, there are newer biologicals available now. Trastuzumab and dupilumab
Absolutely.
are sort of acting against these. So you're right that we have to sort of type the patient first. She did mention that the IgE was raised, but I could not sort of
What level? Yeah.
remember
So
what
coming to
level
the
it was.
test
And
now. So
yeah,
meanwhile, we have the test here. So the TLC was about 5,600 per microliter. Absolute eosinophil count was 500 cells per microliter. Total IgE came to 2,500 international units per ml.
Okay.
IgE for aspergillus was 45 Ku per liter.
That's a
And
good kitchen. Yeah.
IgG
Okay, you got it. Okay.
was 30. So going forward now, Dr. Abhinav, would you like to change the management at this point of time?
at this point of time, of course not. So
So
I,
acute management,
we
of
need
course,
to
we'll be through.
we
Yeah.
need to save the patient. Only one addition. So since you said that this is an eosinophilic asthma now,
Yeah.
there are papers, not papers, I would say just a paper that benralizumab has been sort of approved in such an acute exacerbation of asthma, which is an anti IL-5 agent, which reduces the amount of eosinophilic asthma. But I have my doubts on whether it will act so fast. And I can see Dr. Ramesh nodding that, of course, this is just a paper. We definitely need more data, and I would not sort of alter my management with these reports. From what you are inclining towards is probably this is not just asthma. This may be ABPA, which is
Absolutely.
a variant, and we would need to sort of address that, and that is maybe the reason why the asthma is not getting controlled as yet.
Yeah, I would agree. ABPA is something we need to look at. It's treatable. It's not as complicated as if it were not ABPA.
Correct.
So
But
going
even
forward,
then, the immediate management does not change.
the immediate management, of course, acute management has to be given priority. But
Correct.
going forward, we'll have to look into other drugs which can
Correct.
be used and which will be needed, including safe antifungals and steroids.
So right
So
now, I don't think there is any question about safety. The
safety of the mother takes
safety of the
priority.
mother takes priority, as Dr.
So,
Sakshi rightly pointed,
uh,
and
so can
we will
you
have to move from that.
discuss the antifungals which will be safe in pregnancy for use in this case?
Mm,
So,
In this case, well,
so for ABP, if I'm not wrong, you give amphotericin B, right?
Yes,
uh,
you're right.
Itraconazole is something they use.
Yeah, but
yes.
Yes, but
It-
azoles are generally not recommended in pregnancy,
In
and she's
pregnancy,
right that
yes.
amphotericin B is
only
could be
low dose fluconazole are
Yes.
actually category B, even high dose fluconazoles are category C. But again, as this patient is more important, she might lose her life. So we have to give whatever is required for her. We have to counsel the relatives. We will see if they are teratogenic. We have a very good genetic setup. We actually calculate the dose. If it's actually lethal for the baby, we might consider the termination of pregnancy once the patient is all right. Or there are a lot of other tests where we can monitor for the any teratogenic effects which come up.
right. And any other tests, immunological, or what do you think about the radiological test? Just a word on that.
So for fetus, we just need to get right now an ultrasound just to see where is the fetus located. It's an intrauterine sac and whether the cardiac activity is present or not, as it helps us in prognosticating the family. For all we know, it's already a cardiac activity is not there, and in an 8 weeks fetus, it's already a missed abortion. So any which ways, it makes our treatment all the more easier because the mother is important. We'll treat the mother, and then we'll take care of the pregnancy later. But in case it's a pregnancy is positive, since it's a cardiac activity is present, we counsel the family. Mother takes the priority over everything.
Right. So, Dr. Sujata, again, can you just about say word on risk factors for exacerbation of asthma in pregnancy? Again, we have discussed many of those. And anything else which could be like?
So I think the most important thing from a practical standpoint is this fear of using medications. So they always underdose the medications. And, obviously this patient had to be reassessed to see once the acute crisis is over, what optimal preventive medication that can be used. And if it means that her control will be doable only with a biological, then she may be a candidate for biological treatment. But for the most part, it's poor compliance, and that's the biggest thing that we need to deal with. See, address comorbids. Reassess the patient. Reassessing the patient is pretty simple once this crisis is over. A simple CBE, CBC, or total
Absolutely.
IgE, and maybe, a chest X-ray definitely should have been gotten. Otherwise, a high resolution CT at some stage down the line. So some of these basic things we need to look at.
Right.
And as I said, you really need to reassess that immunotherapy and see what that's doing and what combinations they've used. And, a lot of times I see people, just put various combinations without really having a clear-cut, significant positive skin test. So there is really no indication for starting that allergen. So that has to be clarified also.
Right.
And again, if she's a smoker, if she's exposed to some other unusual environmental irritant, that environmental assessment should also be done, because she's probably an ABPA candidate. We also have to see in certain conditions where there's a lot of mold and the monsoon areas. I've seen patients where they've actually had this Aspergillus niger, black mold, which you don't see, but it happens under cracks. And if you're exposed continuously to that can really cause a lot of such exacerbations and significant damage down the line. So we need to reassess her environment also. It's important. Or if she has a pet cat and she's very allergic and,
Right, you have to take care of the modifiable factors. So moving on to case 2 now. So we have a 30-year-old diabetic patient with about 12 weeks period of gestation. She has a BMI of about 32. She has history of moderate to severe atopic dermatitis and has various food allergies, including she's allergic to milk, peanuts, shellfish. She has been on relatively monitored high-dose steroid applications, calcineurin inhibitors, crisaborole prior to pregnancy. And she was started in dupilumab, 200 micrograms, 2 weekly for 4 months now. What will be recommendations for managing this patient? Continuing, discontinuing, upgrading the drugs, side effects, and managing flare-ups. Dr. Shilpa, if she's here.
I'm here, ma'am. So I think she's already on the top of the mountain. All drugs are already given. I have never used dupilumab even in a non-pregnant person.
Right.
And like I said, in an Indian setup, we don't see very severe cases of atopic dermatitis. Maybe it is still a very bad, severe manifestation are seen in the West, but our side is relatively okay. And skin diseases normally, people are very conscious. So itch is very disturbing. Patients don't come up with a very severe disease. They come very early. So you are able to manage them also. I have never seen a moderate atopic dermatitis patient also in pregnancy, let alone severe. So I don't think so there's anything more to top up here. She's diabetic, so we can't really go in with little 2 to 3 weeks of steroid. That's the only thing that is not used. And I think it's an unimaginable scenario. Because she's on all topicals, she's on
Right.
the injectables that she has to be. And we can start her on cyclosporin. That's the only drug that remains. But I don't know, practically, I have yet to see a pregnant patient being put on cyclosporin. So I can say that very theoretically, but practically, I have never used any of these drugs.
Any of these drugs would you like to discontinue and manage differently
The
in terms of, say,
no,
side
ma'am.
effects or?
No. I think she's a diabetic. If there is a drug she can be on, it has to be dupilumab. and she's already on topicals, and we've spoken on topicals, and if she's on injectable, then topical therapy is any which ways, way behind. Only when she recovers, then we can just come down to topical. But I think cyclosporin is the way up, otherwise nothing more.
Okay, going forward, at 28 weeks period gestation, patient presented to the emergency with swelling of lips, rash, subjective urticaria, and hypotension. There was a history of ingestion of some Thai food with peanuts or satay sauce. So we've already heard a lot on this topic. But Dr. Sujata, just a quick word again.
Okay, so going back to this patient, 32-year-old with atopic dermatitis, allergic to milk, peanut, and shellfish. So she is a patient who's severely atopic. She's got significant food allergies also. So satay has peanuts. So, she would have been inadvertently exposed to peanuts. Right? So she has got to be careful. She's got to be educated. She needs to have her EpiPen. Now, regarding dupilumab, actually, dupilumab works wonders in patients with severe atopic dermatitis. There is no category assigned to pregnancy. So if you look at cyclosporin, it's category C, whereas dupilumab, there's no category assigned because studies have not been done, but they say it's relatively safe to use during pregnancy. It's 60,000 rupees an injection or a lakh a month. So she must be very rich to afford it. But when you do initiate dupilumab clinically, you see a wonderful response. I think you mentioned she'd been on 3 months of dupilumab or 3 weeks.
4 months.
Sorry?
4 months.
4 months. So she should have seen a response to the dupilumab. 1 or 2 months, you definitely see if their responders a significant clinical improvement. Certainly she's somebody who definitely should have her EpiPen. She's got to read labels. She's got to be very careful, especially when you eat exotic cuisine. Because especially if you look at Malaysian food, you look at Thai food, there's a lot of peanut in their satay and all of that. So you have to understand and communicate also that you don't eat a lot of things. So preventive vigilance is key over here.
And would you like to go over some of the more common antepartum and intrapartum causes of pregnancy or anaphylaxis in pregnancy?
Okay, so the other thing with this patient, one thing you can use in this patient would be during the course of pregnancy, if she's going to be exposed to a lot of course, counseling, prevention, etc., etc. If she's somebody who's traveling and who can't
trigger avoidance,
Azolair, that is anti-IgE, that is something we could consider using. We have used that, for example, in teenagers who want to go abroad for a trip. For a short time, we have used the anti-IgE because you reduce the IgE, you reduce the incidence of anaphylaxis. And you were asking, sorry, other causes of anaphylaxis during pregnancy?
So the relatively more common, we've already discussed some of these like food allergy, especially antepartum and all, will have the similar incidence in pregnant and non-pregnant patients.
Right.
But what are the more common causes of anaphylaxis in the antepartum and intrapartum period? Maybe Dr. Sakshi could help us with that. What has her experience been with this?
So, as Dr. Sujata has already said that the maximum kind of anaphylaxis happened during the cesarean section. And it's probably because of the antibiotic shot, which we have given just prior to the cesarean starting. We just at the nick of the moment we give the nick at the skin, and suddenly the anesthetist says she's having a reaction and quickly take out the baby. And this is the generally thing which has happened with us. And they're generally to the beta lactams or very rarely to the anesthetic agents. That is one part. During labor, we have not seen so much amount of anaphylaxis, to be very honest. We have seen during the cesarean section, and we're always thankful that the anesthetist is always there at a standby.
The other thing you should think of, which is very common, we have not mentioned, is NSAID allergies, especially in females. It is the commonest cause, I would say. I mean, yes, you have a heightened incidence of penicillin allergies because you use it more during C-sections. But NSAID allergy is something, so many cases of anaphylaxis when they say they gave the antibiotic, but actually it's the pre-op meds that they give. And it's not the anesthetic agent, it's the NSAID which is responsible for the anaphylaxis. So
normally, we've not seen with NSAID so much, but we have seen with the antibiotics a lot, especially with the beta lactams.
Right.
Not with NSAID so much. Not like to the category of anaphylaxis. Mild degree of allergic reactions, but not anaphylaxis.
So two other things, like recently there have been a lot of case reports of anaphylaxis to chlorhexidine coming from NHS,
Right.
severe cases of anaphylaxis. And another thing would be allergy to iron. Have you encountered that in you? And
Yeah,
what preparations would be
Iron.
relatively
Okay.
safe?
Yeah, so iron drips does cause allergic reactions, but to the category of anaphylaxis, I have not seen so much. But yes, with iron drips, we are very, very careful whenever we are giving. We always admit the patient and then we give it with the initial part very slowly. And with the ferrium carboxy maltose coming in, it's generally given slowly and then it's finishes within half an hour or so. And we generally keep ready the adrenaline and hydrocot along with it whenever we are giving it. So iron, yes. And also recently we had a very severe case of anaphylaxis to tranexamic acid. That's the drug which we had not seen so far, but a patient had a very bad postpartum hemorrhage. And during the cesarean, we managed it. And postpartum, we just gave it an exmic shot to maintain it. And she had an anaphylaxis, and we had to rush at 2 a.m. in the night just to see she's all right. But as adrenaline worked wonders, epinephrine had been given, hydrocot had been given, and she was absolutely all right when we reached the hospital. But tranexamic acid, yes, one which we had not seen so far.
Okay. Just to one thing further that I would like to discuss, this case scenario is not necessarily the same patient. About 32 weeks of gestation, a patient was showing excessive weight gain, about 25 kgs, had rash suggestive of urticaria all over the thighs and abdomen, had development of papules, coalescing plaques, debilitating itch with lack of sleep, and poor response to antihistaminics and steroid applications. So, Dr. Sakshi or Dr. Sujata, would you like to take a guess on what it is?
Sudden weight gain is your clue.
Right. And also the clinical presentation, the progression from urticaria to papules and plaques.
It's a case of an atopic dermatitis, I guess, like a severe case of an atopic dermatitis, or Dr. Shilpa will be able to help us
Yes, I
better
think
with
pruritic urticarial papules and plaques of pregnancy.
Yeah,
Yeah,
pops. Pops, yeah, okay.
So how will you manage this case? Like, how will you help the patient in this case?
Yes, so ma'am, if we've given anti-allergic and we've dosed the anti-allergic also, and potent corticosteroids have been given, I think the next step would be to put the patient on a short dose of oral corticosteroids.
Okay, and
So,
what do you
so
think?
if you look at pups, pruritic urticarial papules and plaques of pregnancy, it's a very frightening looking thing because the patient has flagrant rashes. I mean, it's all over. And sometimes they're extremely uncomfortable. Sometimes, despite those, crazy lesions, they're relatively okay. For the most part, as was mentioned just now, you would certainly treat with the antihistamines, maybe a course of steroids. The tendency is either it gets better or worse or remains the same during pregnancy. So you pray that it gets better during pregnancy. But though it is very flagrant and very frightening looking, it clinically, I don't know if you'll agree with me, and
Patient
the
is
number
not
of
so uncomfortable.
not so uncomfortable,
Yes.
actually. It's very frightening looking, yeah.
Yes.
Well, I like to differ on that. Actually, the patient was me. I had pups
Okay.
during
Yeah,
pregnancy.
right. It's fine. Yeah,
And
some
it's
patients, they're
absolutely
miserable. Yeah.
distressing condition.
Right,
And
yeah.
I think that none of the medications worked. What really worked was exposing myself to cold at the peak of winters. So cold is something which, and cold compresses, which really chilled in. And again, you have to go in for an early. Thankfully, it occurs in the latter part
Yes.
of pregnancy. So you can go in and plan an early or term delivery for this. So I think that's the end of our case discussions for now. Dr. Neeraj, would you like to?
So I think it is very fruitful discussion, and I was just listening. And when we were thinking about this topic of allergy in pregnancy, so why this topic came to my mind, because there were few patients who were actually pregnant or and then they were having some issues with some hormones, as rightly mentioned by progesterone or so. Then at that time, it was like I still remember one of the lady who has undergone 3 abortions just only because of this reason, and she is in so miserable condition that what to do next and how to proceed next. So these were these different type of things which are there, and that came to my mind that let us discuss about this topic more. But I must say that I think you all have done really wonderful. So I will just pay my regards to every one of you. As we come to close of this insightful and deeply meaningful webinar, I would like to extend my heartfelt thanks to every one of you who made this evening a successful evening. First and foremost, sincere gratitude to all our eminent speakers and panelists, Dr. Ruhi, Dr. Abhinav, Dr. Shilpa, Dr. Sujata, and Dr. Sakshi for their evidence-based presentation and rich clinical perspectives. I thank each of our expert panelists for sharing practical pearls on collaborative care. A special thanks to our moderator, Dr. Veena, for skillfully navigating the panel discussion. We are also deeply honored by the presence of our chief guest, Dr. Neelam Mohan, whose support and encouragement continue to inspire our academic journey as always. And our public awareness flyer on allergy safety in pregnancy, released today in 2 languages, is another small but impactful step in patient education. And I would like to thank my colleague, Dr. Vikram Patra, who is behind its design and translation. To all delegates and attendees joining across the country and beyond, thank you for your active participation. We hope today's session have added value to your practice and understanding. Finally, I would like to acknowledge the dedicated efforts of entire IAP Allergy Applied Immunology chapter and team who work tirelessly behind the scene to bring all these webinars to life. And all these webinars are actually available to our YouTube channel. So the people can go back and then they can just relax, enjoy, and learn more and more. So let us continue to collaborate, educate, and advocate for safer allergy care, especially for mothers and their unborn children. Wishing all of you a safe and happy journey ahead. Thank you so much. Thank you for your active participation and collaboration. Thank you.
Thank you
Thank
so
you.
much.
Thank you very much.